she was reporting significant sleep issues at that time.
I was aware.
And then as far as the course of treatment at the clinic, were you able to review her course of treatment with Julie?
I was.
And fair to say that had been very recent, correct?
Very recent, yes.
Her first contact with the clinic was actually November 20th, correct?
Correct.
So you were aware that Julie had originally prescribed Prozac and had already changed the medication plan.
Yes, I was aware.
So in this meeting on November 29th, what was Lindsay reporting to you as the issues?
Let me tell you this.
Would I be able to
I
refer
was
to my
born
note,
in Presley,
Your Honor?
and I will die.
I know most of it by memory, but just so
And
she
that's
had
what I
been
can
taking
say for you.
mirtazapine, Remeron, at that point for 4 nights. So I believe she started it on November
It's more
25th.
than you
I was
ever
then
will
seeing
be.
her on November 29th.
My parents held on there and stayed.
She wasn't yet
I'm not
appreciating
afraid.
much difference from mood, anxiety, or insomnia. She would say, you know, I'm able to fall asleep for 2 hours, then I'm up for 3 hours in the middle of the night. And finding herself like in those 3 hours needing to take an Ativan to help her fall back asleep.
Now, when she said not appreciating much difference after taking it for 4 nights, in your training experience, is that something that you would normally see with that type of medication?
Yes, I wasn't surprised by that.
And for something like mirtazapine, or what's referred to as Remeron, right?
Remeron, yeah.
What class of drug is that?
It is a noradrenergic specific serotonin antidepressant. So it's slightly different than an SSRI. It does work on serotonin. It also works on the noradrenergic part is alpha receptors, which is what our body, those are the receptors that our body responds to adrenaline. So it should help kind of calm you down. And it also works on histamine receptors, which is why it can make people sleepy.
So for Remeron, the fact that it has a calming effect on somebody with anxiety,
Oh my
it's
goodness.
sometimes a
Good
good
morning.
fit,
We're
right?
straight into
Yeah.
the
And for
Lindsay,
somebody who might be
Clancey
complaining of
call.
sleep issues, it also has that secondary component that could help.
Good
Yeah,
morning,
it is
good
a
morning.
good choice for somebody who's having depression with prominent anxiety,
Okay.
insomnia, decreased appetite, because it can also increase appetite, which sometimes we want to happen.
And based on your view
A little
of
early this morning,
her
ringing
course
into
of
the trial
treatment
this morning.
with the clinic, those were issues that had arisen.
How many's been
right?
watching since
Yeah,
they
I had
started,
noticed she had
before they
lost
started?
weight when she had gone to her PCP on October 20th. I believe she weighed like 130 pounds. On the 16th, when she went to the ED, she weighed 124 pounds, and they had done a pretty good medical workup on her with labs and everything. And she had reported like decreased appetite. So that was part of the clinical picture. And of course, not sleeping and very anxious.
Okay, and so with a medication like Remeron or mirtazapine, does it take time to work or to see results?
Yes.
And typically, what's the time frame for that drug?
I usually tell patients 4 to 6 weeks at a given dose is really going to give us a good idea of what that dose is going to do. You may start to see improvements in the first 2 weeks.
Good morning,
but,
y'all.
full clinical
Welcome
benefit can
in.
take
We've made it to
a
Tuesday.
month,
Hey,
sometimes 8 weeks even.
I'm live
And
on the Big
you
Watch
were aware prior to her coming to this
talk
follow-up
about this
appointment with you
case.
that she had been reporting after taking the Remeron, feeling disoriented, forgetful, not feeling connected to the body, and anxious
And-
about whether she would
Excuse
actually
me.
sleep.
Correct.
Oh, thank you. I
and so
appreciate it. I appreciate y'all
Were
taking the
you
time
aware
to come
that
here
on
and
November
talk to me.
28th that one of the
So
nurses
that's
actually advised
that's how we
her
get folks
to
in here.
increase the
But I have
Remeron?
to say, I have to
It was.
ask.
And
Well,
in
what did
addition
you
to
think
the
of
medication, there was also the
Reddington's
recommendation that she add some
mentality
cognitive
yesterday when it came
behavioral
to
therapy
Dr.
to her
Cook?
treatment plan.
Yes.
And at that point on November 29th, by November 29th,
Don't
were
you
you
feel
aware
like
of whether
he
she had met with
absolutely wore
the
her
social
out?
worker at the clinic?
Like
She was not.
flatlined her.
So did you have
No
any
mercy
indication that she had been engaging in some
whatsoever.
sort of cognitive behavioral or
When you come in, let me
psychotherapy?
know what you're doing.
No.
What are you thinking about doing? Send me your
Now, in
heartbeat.
relation to the
I'm with you
medication
today.
piece of this follow-up,
As far as the trial
did
is
you have any
concerned,
conversations with her
until our
about
first break, which should
the
be around
concerns with the
lunchtime. I'm
Remeron
going to come
and
on a
what to
little
do
bit
about
early. so we can follow your
Yes,
testimony.
I did.
Okay. That was a tough one yesterday.
I explained
It's
to her
hard.
that it takes
was
time
hard for me to listen
work,
to that because
that it has only been 4 days.
this is a young
Um,
doctor and she's
so
probably
I did
learned a lot
encourage
of
her to give it some
lessons.
more time.
Um,
I also made
did it
additional
hurt her
recommendations
career?
as
I
well.
don't know. I don't
Okay.
know.
And so what were the
Life is the only
recommendations
time will
for?
tell when it comes to that.
I had known that Julie had
Yeah, the
tried
notes
like 5
thing, Nick,
milligrams of
to me,
Ambien.
like,
So I had suggested maybe we could
she
try
didn't really
10.
do a good
Maybe we could
job
try Ambien
notating
controlled
everything.
release
She
formulation.
kind of,
Because
I'm a
because she
note
was having
taker.
these wake ups in
Like
the
if
middle of the night, the controlled release
I
kind of like
will
the outer layer
write
gives you
every
60% of the
word
dose,
down,
helps you sleep.
every
And throughout the
word.
night, the inner layer gives you
And there
40% of the
is
dose,
an
keeps you
unlimited
asleep. I
amount
said
of
that might
paper
be a good
supply
option
for
while
her to
we're
do
waiting for
that.
the
So
Remron
I
to work.
didn't agree with her note-taking skills.
Because I was sort of
Now, could have
thinking
she
that maybe the underlying
foreseen
depression,
that somebody
anxiety
was going to
was
take the
causing
life
the
of
poor
3
sleep. So while
children?
we're treating
I
that,
don't know.
let's
We
try
weren't
these
even young.
alternatives.
Okay. And so was she receptive to the Ambien?
No.
And did she say why?
No, I don't recall.
Did she express to you that she had some other concerns about taking certain types of medications for sleep, like benzodiazepines?
She did.
What'd she say about that?
Was concerned about taking benzo. She had mentioned something called rebound anxiety. And what that is once the dose sort of wears off, your anxiety goes like above your baseline once the dose of a benzodiazepine wears off. It usually typically has to do with half-life of a medication. So for Ativan, that's usually between 8 and 24 hours. So if she's taking it in the middle of the night, the next morning she would feel more anxious. She was concerned about that. She also feels she was concerned about getting physically dependent on it because she had needed to take it for a number of nights.
And when she used the term rebound anxiety, was that her terminology?
Yes, it was.
And is that a terminology that you generally use in psychiatric care to describe that, what you just told us about?
Yeah, it's a clinical term.
And was that something that she mentioned first, or did you mention?
I put it in quotes in my notes, so she had. That's usually when a patient mentions it. I put it in quotes.
Okay. And so, as far as the plan to address the sleep and to help her with this complaint, with Ambien not a choice, what was your next recommendation?
I discussed hydroxyzine because it's an as-needed medication for anxiety, but it's not a benzodiazepine. Doesn't really carry that risk of rebound anxiety or tolerance or dependence, and it could help her sleep. So I offered that as an alternative as well.
Were you aware that she was offered hydroxyzine before?
I was not aware of that.
Was she willing to try the hydroxyzine?
No.
And so what was her preference?
Her preference was to continue with the mirtazapine, the Remron 15 milligrams, and with the as-needed lorazepam.
And just so we kind of stay with the same terminology, when you're talking lorazepam.
Sorry, Ativan? Yeah.
Okay. And that was something that she expressed to you?
Yes.
Now, when you're dealing with a patient, and obviously this
sorry.
is your
I was
first
saying
interaction with her, right?
I was saying that I've been real hard
Do
lately.
you
So
take
tired that
into
I
account
have to mute myself.
your contact and
But thank
communication with
you
them and
for that.
assessing whether they have the ability to make these choices or make informed decisions?
Absolutely.
And so your conversation with her about her medication treatment that she had received and what you were proposing as a plan, was she able to engage with you in that conversation?
Yep.
And so when
it was collaborative.
And so when she declined the options that you first offered, did you then present her with alternatives?
I did.
And ultimately, at the end of the day, whose choice is it as to what medication regimen person would be on?
The patient.
And why is that?
Because they have autonomy in their decisions. I'm only making recommendations based on my education, experience, training, what I'm seeing in terms of symptoms. The patient has the autonomy.
Are there instances where you're dealing with a patient where you have concerns that they shouldn't have autonomy? Or that maybe if I rephrase that question, are there instances where you're dealing with a patient where you're concerned that they don't have the ability to make the right choice for themselves?
There would be, yeah.
And what options do you have in those instances?
In those instances, I mean, that sort of comes down to like competency, capacity to make decisions. Sometimes we might get our legal or ethics team like involved to make a determination about whether this patient needs like a healthcare proxy to make their decisions, things like that.
And what about if a person presents with a very serious risk to their own physical health or the health of others? What are your options then?
Good morning, Katie.
I guess it would
Follow
depend,
YouTube if you guys
you
want
know,
to
if
know
they had
what
capacity
it
to
is.
make their decisions.
In your interaction with her on November 29th, did you also go through with her and perform a mental screening test or a mental status screening?
I did.
And why do you do that?
It gives me some like objective data of how the patient presents, like how is their speech, how's their appearance, what is their thought process, what's their thought content, things of that nature.
And in this meeting on November 29th of 2022, did you
How long
observe
ago?
anything in which she displayed manic symptoms?
Patrick.
No.
And what traditionally are manic symptoms that you look for?
So there's a new
Yep, I heard about that.
mnemonic called Dig Fast. Try to do this quick. D is distractibility. Patient is highly distracted to lots of extraneous
Thank you,
stimuli.
Truth Teller.
There is pressured speech, grandiosity. So like suddenly someone's like,
What
I'm going to run for
pressured
office.
speech? That was
I'm
the
going to
whole
be the
big thing.
president. And you're like, okay, you've never had an interest in that before. Sleep is really poor. So somebody might get like 2 hours of sleep, but be like, go, 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 go. Increased goal-directed activity. So somebody might be like painting the exterior of their house, painting the interior of their house. They might be, you know, doing a bunch of different projects with no like decompression time or feeling tired. Those are the general symptoms of mania. Sometimes there can be psychosis associated with it as well.
Okay. And so when you say mania and psychosis, are those two different things?
Yes.
And so are you also looking in these screenings to identify signs of psychosis?
Absolutely.
And what would be signs
Yeah,
of
I saw that.
psychosis
What does
usually?
it mean? What's pressure?
Signs of psychosis, they can be sort of subtle. It might look like somebody's like responding to, you know, stimuli in their head, like based on the way that their eyes are kind of tracking and they're not really paying attention. They may be quite guarded. They may have a delusional thought process. Like, for example, they might think that like somebody's out to get them when there's really no like basis.
Rapid.
When you say responding to internal stimuli, is that generally when a person hears things, auditory
Hey, somebody
hallucinations, or
always
sees
out
things
to
that are
see
their
me.
visual hallucinations?
Mhm.
And in addition to kind of watching for these things in your interaction, do you flat out ask somebody if they're experiencing those symptoms?
I do.
And in this first interaction that you had with Lindsay Clancey on 11/29, did she display any psychotic symptoms?
No.
What about
Before.
assessing for suicidality? Do you do that
I
as
do.
well?
Mhm.
And what do you do for that?
I generally ask, you know, are you having any thoughts of wanting to hurt yourself or anybody else? And if the answer is yes, it sort of becomes a more in-depth assessment.
Do you go back and ask them about past thoughts,
Yes.
whether they've articulated that?
Mhm.
And in this case with Miss Clancy, did she ever indicate whether she had a history of having
for the
suicidal
Jules
thoughts
Megan.
or suicidal ideation?
She did not.
And how about homicidal ideation? Do you ask about that?
I do.
And in this instance, did she indicate whether she had any homicidal ideation or thoughts of harming other people?
No.
And as far as your observations of her presentation,
donut,
like her mood and physically how she presented, did you anything stand out to you
for the
as far as
donuts.
any of that?
She seemed anxious. That's what I
Okay.
remember.
Okay. So as far as mood,
So commonality, anxious.
So I couldn't hear that.
Sorry, if you can finish your answer.
Sure. You done with that?
Yeah, I'm done.
Okay. All right.
so as far as mood, you noted her to be anxious, right?
Yes.
Welcome.
And you also look at a person's affect.
Mhm.
And did you
You're gonna have to answer
Oh.
yes or no.
Yes, sorry.
you observed her
Let
affect to be
me
consistent
ask
with her
y'all, we'll
mood,
turn
which you
this
identified as
over to you
anxious,
for a
right?
hmm
What?
And
y'all,
you examined
I
somebody
was
with
watching
their
this morning
Sorry.
before the jury came
that's
in.
okay thought
What do you
process,
think
right?
about Reddington?
Right.
Who is
And
this woman on
did you
TikTok?
what did you
I've heard
observe
of
her thought
her.
process to be?
I've not seen any of her
I
videos.
observed her thought
Are
process to
you
be
saying?
linear,
What did y'all think about
meaning
that?
you
Because
could
I
follow
thought,
it
why is
when
the
her
judge
train of
even
thought
thinking about it?
easily, and goal directed.
Why is
She
the judge
understood
even
that she was
thinking about
there
it? I would have said,
to
hell
be assessed
no,
for treatment. Seemed to be her goal.
because
And
it's
do you
weird to
also
me.
perform other screenings like the
We're more than
generalized
halfway through a trial,
anxiety depression scale and the
and
Edinburgh
somebody
scale?
found somebody
I
on
do.
TikTok
And did you do that for Lindsay
who
Clancey
had a
on
bad
November 29th?
experience
I did.
And what were the
the same
results of
center
those
that
screens?
Her
Dr.
So the
Tut
Edinburgh
works
scale
that.
is out of 30. She was 17.
And now
What does that
Reddington
mean?
wants to bring her in
Moderate
as
to
a
severe
witness
symptoms, postpartum
on a
depression.
trial she has
Now, with that
nothing to do with.
particular screening tool that you can use,
It's
is it fair to
weird
say
to
that
me.
with postpartum women, it often
It's
fluctuates?
weird to me.
It can.
She's been
That,
watching the
it's
trial.
The patient is asked about the previous 7 days.
It's
And
weird.
as far as the generalized anxiety depression scale, what were
It is to
the
me.
results of
It
that
is to me.
screen?
I've never, but the reason it's weird is because have you ever heard of that?
14.
Have you ever heard
out
of
of
a
a total of
trial
21.
more than halfway through?
And so what does that mean?
We're
That would mean
centuries past
moderately
discovery.
severe anxiety.
And somebody's watching TikTok and says, we
And
need
do you
her in
recall
here as a
how
witness?
much or how long your interaction with her was on this telehealth visit?
It would have been 30 minutes.
Yeah, I don't know.
And
Manuela, it's going to be
as a result of
4
your
weeks
interaction with
probably.
her, did you come up with
But y'all
a
don't-
plan
I mean,
moving forward as to what to do
What?
to address her
It's
issues or her
ugly.
concerns?
I don't
Yes.
know.
What
What did
was
we
the
do
plan?
before TikTok?
Continue Remron 15
Don't you think it's
milligrams
up
nightly,
to
Ativan
the
as needed.
defense
Those medications had been
to
prescribed
get
to
all
her
of their
already. I did not
witnesses
write her any
ducks in
prescriptions
a
at that
row
visit.
before the trial starts?
And again, you indicated
You're going
that
to
you
interrupt a
kind of
trial
encouraged her to
now
stick with
to
the
enter a
Reverend and
witness.
give it a
Now you
chance
got
to
to have
work.
the
Yes.
defense
Was she receptive to doing
and the
that?
witness
Yes.
to.
And
Okay,
as far as, again, the
I
sleep
don't know,
issue, based on your conversation with her and her
I would have
request
said.
to continue with the Ativan, that's what you recommended?
I would have said your window has closed.
Did you also recommend
If you don't have all your
types
professionals
of,
by now, we're not bringing in
treatment that
anymore.
were not
There's like I
pharmacological?
totally agree.
Yes.
Whether you
And what were
agree
those?
I
that
recommended
Lindsay needs
therapy,
a
mindfulness,
not guilty plea because of
physical
insanity, or
activity,
she needs to go to the king.
meditation.
And you're aware that
whichever.
in the
The
past she had
due
reported
process
physical activity
is
was
being
something that had been helpful to
broken.
her.
Yes, I
That was a
believe with
break to
her
me. No, because if you
postpartum
open
period
that
with
up,
Dawson, her middle child,
now
she had some
everybody
anxiety,
who
but it
ever
seemed
went to that
resolve
clinic
with exercise.
is going to give their
in
opinion on
particular.
TikTok, and now you got to call them,
And fair to say, as
and we'll never get
as
through
it
this
pertains
trial.
to that experience or postpartum with Dawson, she had reported at some point to the clinic that she had sought medication after having Dawson and that she didn't end up taking that medication, right?
Correct.
Now, after this particular follow-up, what's your practice when you're dealing with a patient to have them have an intervention if they need to get in touch with you or they have concerns before your next scheduled meeting?
I'm sure you can,
I generally advise
but to
for
somebody
non-emergencies,
randomly,
you can message me
not
on
random.
the
I mean,
Epic
I'm
portal.
just TikTok.
Is that generally referred to as my chart?
With
I
my
believe
chart,
in a
yeah.
fair trial.
And
I
so
believe
my
if you
chart, you
bring
could kind
somebody
of
in from
go back and
TikTok
forth with messages, right?
who
Yes.
Did you
may
encourage
even have
Lindsay
changed
to
their
utilize
opinion,
my
not based
chart
on their
if
experience,
she
but
felt the need
based
to
on
reach
how
out
they
to you
see this
before your
trial
next
going.
scheduled
Could be
appointment?
right.
Yes.
It's too
And
tainted.
at the end of that meeting, what was the plan
Too
for the
tainted
next
for me.
scheduled
You gotta
appointment? What
keep it
was
separate.
the track that you would ask her to be on as far as regular visits?
1 week.
And is that typical, 1 week?
1 to 2 weeks. would be typical for a new patient.
And based on her report of symptoms or potential symptoms, was it important to you to identify if there were any changes?
Absolutely.
Now, were you aware by the time that meeting was completed that she did have an appointment scheduled with a social worker at your clinic, Letitia Dukes, for December 2nd?
I was aware of that, yes.
Now, after this meeting, so this was approximately 10:30 in the morning on 11/29, right?
Yes,
Did you have communication or contact with Lindsay Clancey on November 30th?
I did.
How did you have contact with her on that day?
She messaged me on the MyChart portal.
And you're aware that on that particular morning, Julie had informed her that she was leaving?
Yes.
Or were you aware, I should say?
Yes.
Now, when Lindsay messaged you, that was at 11 a.m. That was the first message, correct?
I would have to look at the note for the time.
Okay. Do you have those?
I do have the messages. I believe that'll be accurate. It was 11 a.m. Yep.
And did she ask you something specific in that message?
She did.
What did she ask you?
She asked me if it would be safe to stop taking Remeron after 5 nights.
So you had just met with her on November 29th
Correct.
and talked about stopping Remeron, or talked about the concerns with Remeron.
We talked about continuing it on the
Okay.
29th, yes.
But as far as the starting of that meeting, or where you were talking with her about the medication, she had already reported concerns with that medication, right?
Yes.
And so you encouraged her to stick with it.
Mhm.
And then the next day, she's asking to stop again.
Yes.
Do you recall that in that message, she indicated that in the course of that night, that the depression,
Yes.
she felt like the depression was much, much worse and not helping her sleep, and that she only got 2 hours?
Thank you for your heart meal. Your heart
Yes.
meal alone.
And she asked for a phone call from you, right?
Yes.
And did you call her back or did you message her back?
I messaged her back, but I also believe I had my nurse call her back because I was in between patients.
Okay. And so when you messaged her back, what did you ask her about to address that concern about stopping the Remeron after 5 nights?
I asked her what symptoms of depression did she notice was worsening,
And why did you do that?
because she had mentioned that she felt that she was more depressed. She was attributing it to the medication.
But in her original message, did she give you any detail about what was
Oh,
worse?
yeah, no, she did not. Sorry.
Is it important to you to know
Thank
what
you for
symptoms
that.
are worse so that you know how to advise the patient?
Thank you.
Absolutely.
I've never even heard of that, Kara.
And did you again express to her a concern with stopping that particular medication after the short period of time she had been on it?
Yes, I shared with her that from what I understood, there had been really short medication trials since October, a short course of the Zoloft, a short course of Trazodone, and now what would be a short course of the Remeron. And I reiterated that sometimes it can take 4 to 6 weeks before these treatments start to work.
And you also knew from Julie Paul that she had only taken Prozac for approximately 4 days.
Correct.
So even though you gave her that information and encouraged her to
that's
stay
a
with
walk.
it, did you suggest an
Oh
alternative?
my gosh.
I did.
And why did you suggest an alternative?
At this point, I'm trying to establish a therapeutic relationship with her as a patient. So I had met with her on the 29th. She's concerned about the mirtazapine. I'm kind of asking her to hang with me on it and give it a chance. But then the next day she's asking me again that she really doesn't like it. So at this point, I'm trying to kind of give her an alternative to establish a collaborative therapeutic relationship.
And at the end of the day, if you prescribe a medication and the patient doesn't want to take it,
Right.
you don't know if they're going to take it, right?
Exactly.
So what was the alternative you suggested?
I had suggested Prozac again, just because I had known that she had taken it in like 2012 whenever she was in nursing school, and she was able to take it for a year, and she tolerated it okay. So I was kind of thinking maybe we could try to get you to retrial it, and it would be helpful.
And in making that recommendation to potentially restart it, had you reviewed the notes from Julie Paul in which the defendant, or Lindsay Clancey, indicated that when she took the Prozac, she felt disconnected, and that she was concerned about that, and that Julie had told her to stop it.
Yes.
But you still felt that it was worth giving it another
What do you
try.
guys think about?
And did you
I
suggest
want to know your
anything
opinion in
else
the comments. Here, Marissa.
to pair with the
Tell me how you
Prozac
feel
to help sleep?
I
about
did.
the fact
What did you
that
suggest?
Lindsay
I
didn't
recommended
really give
Seroquel,
any
25
sort of
milligrams.
one medication 3 or 4
And now
weeks to kick
Seroquel,
in
is
to see what
that a drug
happens.
that
That
you're
they-
familiar with?
I am.
And in your
She switched
practice,
so much.
especially dealing with
me know.
women's health, perinatal issues, what would a low dose of Seroquel accomplish for a woman postpartum?
To get them to sleep.
And you are aware that Seroquel at higher doses could be used to treat other types of mental illnesses.
Yes.
But in this circumstance and with this recommendation, what was the purpose of the Seroquel?
So at this stage, my awareness was that she had tried a first line option, which would be the benzodiazepine. The second line options are usually what we call the sedating antidepressants like trazodone, Remeron. So this would be more like a third line option to try.
And is that because
Would there be a
trazodone
point
she
where they
reported
have
didn't help
It
her,
didn't help.
and she
ran
didn't
about options?
like the feeling on Remeron?
Right.
on medicine? Would they have run out of options eventually?
And so ultimately in that message, you kind of reiterated what your overall recommendations were, right?
Yes.
And it was to continue with the Remeron for another 10 days,
Mhm.
and that the alternative would be to restart Prozac and add the 25 milligrams of Seroquel nightly for anxiety and insomnia. Is that correct?
Yes. Yes.
And so were you recommending that she be on all of those at the same time? That she do the Remeron, the Seroquel, the Prozac?
Yes.
And in your experience in psychiatric care and prescribing medication, is it a common practice to pair low doses or doses of particular types of medications together to effectively manage a person's symptoms?
Mhm.
Yeah.
At this clinical juncture, my thought was the combination of Remeron with the Prozac to treat the depression with prominent anxiety, the Seroquel to help alleviate the sleep.
And you're also addressing the concern of benzodiazepine dependency, right?
Correct.
Did you encourage her to do something to help you to kind of manage her treatment track going forward?
Yes.
What did you encourage her to do?
I had noticed that Lindsay was attributing a lot of her symptoms to her medication. And so I attached to the My Chart message 2 different mood charts. And what those one is daily, one is weekly. What it is it asks the patient each day to rate their mood from like 0 to 3. Good mood, bad mood, normal mood. It asks about like, did you take your medications? What doses? What were they? Check the box. How many hours a night did you sleep? What's your anxiety level? What's irritability? And what I wanted from that was, because it had all those parameters about mood and then also the medication, did you take it? We'd be able to track over time what the progression was. Was it getting worse since we started the medication? Was it actually
agree.
getting better? I just wanted more data.
I've
Were
never
you
even
aware
heard
that she was
of
actually
these.
tracking those things herself?
No.
Now, you continued to have some back and forth messages with her throughout the course of the day on November 30th, correct?
Correct.
So we have, she reached out to you at 11.
Mhm.
You responded to her at 11:52.
Yes.
There's another message from her at
Oh, you are?
12:15, right?
Yes.
And just going back for a second, when you were asking her about worsening symptoms, did you ask specifically about suicidal
Now,
symptoms?
I did.
Do I have a
And
bottle of Seroquel
why
in my cabinet?
those? If she
Yes.
was
I
expressing
very
some
rarely,
depression,
so rarely, and
and
it's the
sleep
lowest dose it
issues.
can be on. I have to
Suicidal
take one
thoughts
for
can,
when
are
I
a
get
symptom of,
overwhelmed
can
with
be a
anxiety.
symptom of depression.
Do I have
And I
Ambien in
just
my
wanted to make
cabinet?
sure
Yes.
I
I take an
assessed that
Ambien
one
every
because
night.
because of its
I have
severity.
been on Ambien for
And
8
And is
years.
that
It works
something
fine
that's
for me to help
important
me
to
go to
do
sleep
before
at night.
you make a
And
recommendation
that was
to change
because
your
I
medication?
have severe
Yes.
neuropathy, and I was getting
Now,
woke up in the middle of the night,
when
being
she
freaking
responded at
tased by the
12:15,
universe, and I
did she
couldn't
tell you
sleep. So
anything
that's why
about the
those
suicidal
two.
thoughts, or if she was having
My
any?
other stuff is like for blood
She said she's not
pressure
at the point
and
of being suicidal.
Cymbalta for.
Okay.
I'm on Cymbalta for
Um,
depression, and it
She
also helps
also
my
indicated,
neuropathy.
but I'm really
But
feeling as
most
if
of
I
these,
can't go
I
on
have
like this,
no
right?
idea. I
Right.
didn't realize there were so many.
And she
And
asked you to call in the Seroquel.
She did ask me to
Who
call in the
sits down and
Seroquel,
comes
yes.
up? I've always
So based
wondered
on
the
her
mind of a
response,
scientist. How did they
did
figure this
you
stuff out?
feel that she was taking the alternative that you were offering?
Yes.
And then at 12:29 p.m., you get another message from her where she asks for a phone call, right?
Yes.
And again, at that point, did you have a phone call with her? Or did you continue to interact with her on the MyChart portal?
I interacted with her on the MyChart between patients, and I had my nurse give her a call.
So
And
far, this NP
again,
sounds
you
more
said in
thorough
between
than
patients.
Dr.
So
Cook.
did you have the opportunity to pick up the phone and call?
I did not.
And is that one of the benefits of the messaging portal, that you can get back to somebody quicker?
I
Yes.
think I've had either of those, Grace.
So when, before you were able to respond, did she send you some additional messages on MyChart, if you remember? Or if you could look at your notes.
Okay.
I'm on the Max Cymbalta daily. It treats my nerve pain and my depression. Some people, it doesn't. It hurts. Like some people are saying that it didn't work for me. And I think different medicines work for different people. But if you're only taking them a week at a time and then saying they don't work for you, are
symptoms
they
of
really not
depression
working for you?
that she
That's the
reported?
question.
Yep. So just drawing your attention to 12:58 p.m.
Yes.
You get another message from her where she says, the symptoms of depression that are much worse are just feeling completely hopeless and unmotivated to do anything at all. And that she says, I printed the daily mood chart and we'll start it.
I have a box in my back.
Now, you said that you did ask your nurse to give her a phone call at some point, and so you're aware that a nurse did call her on November 30th, approximately 3:10 p.m.
Yes.
And during that phone call that Lindsay agreed to the plan and that she was going to pick up the Seroquel.
I've heard
Yes.
that one.
Now, at that point, you had another meeting scheduled with her for a week out, right? But
Yes.
prior to that, did you also continue to communicate with her via MyChart?
Yes.
So moving into December 1st,
How
again,
many doses of Cymbalta?
were you able to send her a message?
It feels like
She
the whole
sent
world
me a
is
message
before me.
on December 1st, and I did reply to
Because
it.
I've been
Okay, so
delayed on
December
getting
1st at
medicine,
12:20
whatever.
p.m. We have
2 days
Lindsay
later,
Clancey, hi, Rebecca.
no way.
I really don't like the way I feel on the Remeron, and I know that I can't stick with it, or I can't stick with taking it. I started having very intrusive thoughts that I never had before. I didn't take it last night. I would really like to go back to Julie's original plan of Prozac in the morning and using Ativan and Benadryl at night as a Band-Aid until I get to a therapeutic level of Prozac. Please let me know if you agree with this plan. I know that I need to give it a good couple of weeks to work. Is that the message that you first received on December 1st?
It was.
My question
And
to Kim,
were you aware that that same day that Lindsay had reached out to her primary care physician asking for an immediate appointment with her nurse practitioner,
I was.
and that she was looking to discuss medications?
Yes.
Do you know if she actually got an appointment or went to the appointment there?
They had reached out to her, and she did not respond to their voicemails or MyChart messages, so she did not see them that day, to my knowledge.
So you're able to review the notes from the network of South Shore Health, right?
Correct, yes.
So you were able to review that she asked for an emergency appointment. They were able to find her an emergency appointment, but she wasn't she didn't get it back in enough time to actually get there.
Correct.
And so in the meantime, you're having a back and forth with her during the course of that day, December 1st.
Yes.
When she indicated to you in this message on December 1st about having intrusive thoughts and not liking the Remeron and not taking it, what was your response?
I sent her a detailed message of signs and symptoms of postpartum depression and anxiety, including factors like onset, risk factors, predictors, common symptoms, and it highlighted how intrusive thoughts are quite common in postpartum depression and anxiety. And I asked her, I'm wondering if that's what's going on here. I then asked her if she was able to take the Seroquel that night and if she noticed any improvement in terms of sleep or anxiety.
I've been on Lyrica
with the Seroquel.
Now,
9 years.
by giving you this information about postpartum depression and postpartum anxiety, was that consistent with a diagnosis that either you
My
or Julie
neuropathy is
had
so severe.
given her
It takes.
in coming into the clinic?
Yes.
I've been able to lower.
This could be some
Lyrica.
postpartum anxiety.
This is my medical plan.
And I wanted to
But it still takes the maximum
familiarize
amount of
her with the
Lyrica,
symptoms
the maximum amount
so that she had them
Cymbalta,
written down and she could
and
report them
making
to me.
sure my back is
And
charged every
understand
single
that
day.
they are part of these
If
disorders.
my battery gets low on my back,
And you
if
also
I
gave
go
her
more
some
than
information
24
about
hours without
obsessions and
Cymbalta
compulsions,
or
right?
Lyrica,
Um,
I'm in a world of
And
pain. And
you said you
for
asked her
some
about the
people,
Seroquel and
the
asked
block
to
works.
sleep, right?
Yes.
For
And
me, it
did
takes
you also reiterate that you
everything.
were still encouraging to keep up
Everything
with the Remeron for a
to
period of
work
time?
together every day so that I can
And
be here with
you
y'all.
further indicated
Because
to her
I
that
wouldn't
you
be.
wanted
I wouldn't be
to
able to sit here.
kind of see if there was a correlation between the symptoms and the medication and that you just didn't
It's
have enough
that
data.
Right.
In response to that message, she actually responded at 2:36 on December 1st, correct?
Yes.
And she indicated, thank you for the information. It was helpful. That she says, I panicked last night and just took Ativan and Benadryl, but tonight I'll stick with the plan and try the 15 of Remeron and the 25 of
the same
Seroquel.
one.
Do you recall if you had ever had a conversation
Yeah.
with her about kind of you using Ativan and Benadryl as a backup, or if she just felt like she wasn't getting any relief?
It's called
I
Nevro.
recall having a conversation about
Hold on, I'll
using the
show you
Ativan
here.
as a backup. I believe it was, yes, in my initial, I said continue the Remeron and the Ativan as needed.
Okay.
Yeah.
And what about the Benadryl?
The Benadryl, I don't recall discussing.
But you were aware that she had reported the combination of Ativan and Benadryl had worked for her before.
Right.
And in that message, she also says, I'm sorry for all the messages. It's just a scary, very scary, stressful time for me. And starting new meds with side effects is very scary to me. I'll check in the morning and let you know how it went, right?
Right.
And again, you continued to have some contact with her on that same day after that.
I believe I responded to that, reassuring her that it's understandable to have fears, concerns about starting medications. And I sent her a detailed description of common question and answers I get from patients about medications, things like what to expect, how long does it take to work, what are common side effects, risks for, is there any
Morning,
risk for
Clary.
suicide,
So this is what
homicide
I
with
have.
medications,
So in
Those are
providing all
fine.
this information with her, what were you
I get
trying
out of
to
breath
do?
because there's a tumor I'm fighting in my
provide
lungs right now. It's right here.
information.
So I walk from room to
because
room
she
and
had said it was so scary
fine,
starting
but I
medication,
live.
so I wanted her to
Anyway,
be equipped with
Nevro,
understanding
this
and
is your charger.
what to expect possibly.
There's
Based
the
on
box in
your
your back. This pad
interactions
lays
with her and your
over, and it
review
finds
of
the
Julie
box,
Paul's
and it
interactions with her,
charges the box.
this
And I'll
was a
charge
person
refunding the
that was
charge.
very receptive to
But
taking
when you turn
information,
it
right?
on,
Yes.
And as her role as a nurse,
it
she
starts
was
beeping because it
not
says,
afraid to ask questions.
I need to find your
No.
box.
Yes. She was not afraid.
And one of the
So you gotta
things
take
that
the
you
pad,
provided her, or the information you provided
you
her
go
in
find
this
your box in the
detailed
back.
response back to her on December 1st at 3:04, was that there are other sources or resources that she could utilize that are available at the clinic, right?
Yes.
And
Oh, go ahead.
these two books, Exhibit 148.
Yep.
Good Moms Have Scary Thoughts, and this one.
Sometimes it's hard to find.
Yes.
In
Yes,
my
I
right
instructed
butt,
her
which is
that
where mine is.
we
And
had copies of these books that we were giving out to patients and that she should come grab them when she was in clinic. And she informed me she would be seeing Letitia the next day for counseling, so she would grab them
Okay.
when she was
so
there.
when it finds it, that target is
And
going to
so
light up.
that day, December
And
1st,
the closer
fair to
you
say,
are
you
to
went
your
back
box,
and forth with her from about
the more
12:30
rings you have.
to
Like
her
trying to
last
find
message, she was
a
at
signal.
4:37
And
that
then
day.
you're going to have this
Yes.
battery over here
And
that's
you
going to
said
tell
that she
you.
indicated that she did have
So
an
I was almost
appointment the
dead.
next
I'm less
day
than
with
25%
Letitia
because
Dukes.
only one dot
Yes.
on the battery.
And were you aware
So when
of
the
whether that
bars
was
get to
an
4 and your
in-person
battery is
meeting?
charged, then you can take it
Yes,
off
it
your
was
back. And then
in
you do it
person
again the
because
next
she
day.
said, I'll be in clinic, I'll be able to
It's
get those resources.
so how it works, it's like a bodyguard. So
So moving
both
to
sides of my
December
body is
2nd,
severe
you
neuropathy.
didn't have a scheduled
On a
appointment with
scale
her,
of 1
correct?
to 10,
I did not.
from
And you knew she was
Duke
going to see
University, which is
Letitia
where my
that
biopsy
morning
was sent,
in clinic, right?
10 being
Correct.
normal nerves, 1 being
And you received several
you're
messages
screwed.
from her that morning.
Both of
I
this,
did.
the
Again,
left
through the
side of my
MyChart
body came
portal.
back as a 1,
Yes.
and the right side came back as a 1.5. It took me
Beginning
4
at
years
7:51
to get approved for
a.m.,
the Nevro
where she
implant.
sends you a
But
message
what
saying,
happens
"Hi,
is
Rebecca. I took the
they stick
15
a
Remeron
wire.
and
I have 2
25
wires, one
Seroquel.
up my
I woke
spine,
up at 12 with
and one
horribly
goes around
intrusive
my
thoughts
ribs
of
because I had
wanting it to be all
intercostal
over.
too.
I took 1 milligram
No,
Ativan
it's like
and went
having a
back to
toothache in
sleep,
your
and the
ribs all
thoughts
day
went
every day.
away. Now that I have the
Um,
Ativan on board, I
So
really
they
need to
took
explore
1
the
wire
option
and
that I'm
wrapped it around
addicted
my
to
ribs,
Ativan. I
and
have
they
a
took
therapy
1 and put it
appointment
up
with
my
Letitia in
spine.
your office. I
And
would really
what
like
it
to
does
speak
is
with
when the
someone in the substance
neuropathy
use clinic to
pain,
explore
your
the
damaged
option.
nerves
Do you
send
recall getting that
pain signals
message?
to your
I do.
brain. The box in
And
there tries
did
to
you
act
respond to that
like somewhat
message?
like a bodyguard.
I did.
And it
I
says
am
no.
credentialed at
So
Social
like if
Health
you
and
have no
Addiction
box
Medicine,
and your
so I felt that I
neuropathy pain is
could
straight
be
on
that person
pain,
to
this comes up in the
discuss
middle of
those
it, the
concerns with
box.
her.
And
Just
instead
discuss
of
the
all of it
substance
going
use
Yes.
through,
concerns.
only maybe a little
And
bit,
so,
maybe around.
and
So it
you're
tries
aware
to
that the
de-scramble
social
the pain
workers can also
signals
screen for those as
before it
well.
reaches your
Yes.
brain so that your brain doesn't
So at
interpret it as pain.
8:51 on
Now, I
December
know
2nd, you respond to
that
her,
sounds weird,
right?
but
I did.
And what
so
do you
I
tell
have the
her about
severest
the
side
concerns she
of the
just
most painful type
expressed
of
in her
neuropathy there
7:51
is.
message?
I
Um,
fully
and I have
appreciate and
fibro too,
understand the
Prairie.
concern
So
for benzo tolerance. It's not something I want to happen to
from
my
an
patients ever.
internal pain
That being
specialist,
said, there's
not
a
from
place for
Duke University where they
benzodiazepines,
sit in my
especially
nerve
at the
box.
beginning and acute phase of treatment and getting
But my
someone
internal
stable.
medicine
And then we would
doctor, that's
always
who you
pull
need
back
to see. It's
slowly.
called a Nevro.
I think another thing to
Nevro,
try tonight would be to take 50 milligrams of Seroquel, the 2 tablets, and see
So
if that
slow
works
charging, as you
better.
can see. You can probably see it better with
The
my light.
intrusive thoughts are part of
I got
postpartum
really
depression,
low.
anxiety, very
It's like
painful to think and
struggling right
experience, but I
now.
want to reassure you that it's not uncommon.
And I get busy and I'm
nothing
like,
about
oh
who
my
you are
God,
as
I
a
gotta
mother.
charge my back.
Let
I
me know what
forget
you
to
think.
charge my back. Like I'm the dang
And so
Energizer
the
bunny. But honey, if I don't do it, I can't get
25
out
to
of bed.
50 milligrams of Seroquel, is that still within the range for treatment for insomnia?
Yes.
So would you characterize that as a low dose, a high dose?
Low dose.
What, Candace?
And as far as her statement about intrusive thoughts, fair to say your response doesn't ask her more specifics about those
There's
thoughts, right?
no
No.
complaints for
But
it.
you reiterate to her, just as you had in the lengthy messages where you provided information, that intrusive
Talk
thoughts
to
are
your
pretty
doctor,
common.
Pepper.
Correct.
Now, did she respond to that message?
She did.
And so at 9:04 on December 2nd, there's a response from Lindsay Clancey. I'm willing to try anything. I just keep coming back to the feeling that I'm dependent on Ativan after my 2.5 weeks of taking it daily with Benadryl, following the bad reaction to Zoloft. I feel addicted to it, and I feel like I'm not being heard that is a possibility. I feel like we are throwing all these different meds at my insomnia when the root cause is Ativan dependence.
Yeah.
I don't feel any of the anxious thoughts I had
My mom
before.
had
I feel
COPD.
completely
I
numb.
have diabetes type 2.
So you got that message
and I
from her
have,
at 9:04, correct?
I did.
pulmonary
And
fibrosis.
what
But
was your concern when you got
dear
that message,
Lord,
or did
we
you
are
have
all
any
going to be
concern?
praying for you, honey. We all hate the word cancer
I
here. It sucks. So stand up
wouldn't
to
say I
it.
had
Keep fighting.
concern. I just wanted to, again, provide
Marsha, or you
her
say it like
some
Marsha.
information about what
Is
I
that
thought
your real name, or are you
might
from
be
Harlan?
happening.
'Cause I'm from Harlan County.
Based on your training and
And I keep
experience
wondering
as a
about that.
psychiatric nurse,
Sorry, she didn't finish her answer, please.
Okay, yep. Go ahead.
I was finished.
Okay, well, she's finished. All right, next question.
based on your training and experience as a psychiatric nurse, and you said you had
Oh,
some
cool.
experience with
Well, I'm
substance
from
use.
Harlan, Kentucky.
Did you feel that there was a dependency issue or an addiction issue with Ativan?
I did not.
Is it fairly common that Ativan is going to make somebody
Lots
feel
of
better if
medicine
they're
and a
feeling
back
anxious?
charger, Candace.
Yes.
That's why you take it, right?
Yes.
I mean, you guys wonder.
And that's why you take it as
I know we're
needed. Is
watching
that fair to
this
say?
call, and
Yes.
we're also talking.
So,
you see a
in
lot
your
of people
response to her at
talk like for
9:37,
hours and hours and hours a day, like it never.
do you make
And
clear to her
kudos
the
to
difference
them for being
between
able to do that.
dependence and
But
addiction?
I cannot sit here for probably no longer than a
I do.
couple of hours,
Okay.
and then I have to go
And
do something else.
as far as
Lay down, prop my
benzodiazepines
feet.
go, there's
I have to do
a real concern for dependence and
so,
addiction in the field. Is that fair to
People
say?
wonder, well,
Yes.
why are you only
But
alive like
based
an hour and a
on
half a day?
taking it for
Think
2.5
about
weeks,
that my body has
taking it to address
limitations.
actual
But whether I'm
symptoms of
laying down
anxiety,
in
did
the
you have a
bed
concern
or
of
I'm icing
dependence?
something
No.
in my feet or something,
And so, did you
I'm
articulate to
still
her
on my phone researching and still
that
working on true
anything
crime
about that
and trying,
concept of
because
dependence
my
versus addiction? What
biggest,
did you
I was an
say?
accountant for a Fortune
I said,
500
I
and worked
wonder
hard to
if
get
you
there.
fear you're becoming
And
dependent on
we've
the
got to live my best
benzodiazepines,
life
and
when I
there's a
turn
subtle
40.
difference between
My
dependence and
best
addiction.
decade.
With
And I'm
addiction, there's a
going to be
change in
50 in
behavior
January. So
caused
for
by
10 years,
biochemical
I'm
changes
putting
in the
up with
brain
this
after
shit.
continued substance abuse.
But
The
my
substance
biggest
use becomes the
depression
main priority
was
of the
feeling
person
like
with
I
the
wasn't
substance
a
use
productive
disorder,
part of
regardless of the
society.
harm it causes to themselves or
Because
others.
that's something that's
With
important
dependence,
to
we're
me.
referring to
And that's
physical
something that
dependence
was
on a substance
instilled in me
characterized by
from my
symptoms of
mom.
tolerance. Oh, sorry.
Um,
Characterized by
so
symptoms of
the fact that
tolerance
you
and
guys come
withdrawal.
here every day and listen to me, you
Benzodiazepine
are the
withdrawal
reason
is
I
similar
feel
to alcohol withdrawal
like
symptoms.
I
We would
can
be
still
seeing
function
things
as a
like
human,
elevated
and that
vital
I have some
signs,
sort of
high blood
purpose
pressure,
in the world, or
tachycardia,
that I make a difference, or I will
diaphoresis,
make a difference.
mild alteration of mental
And so
status,
for that, that's why
initially
I
with
say
the
I'm forever grateful
possibility
for you,
of
because it's
perceptual
true.
disturbances,
Without you, I would
delirium,
be in the bed
dysphoria,
wondering
and
what's
tremors.
next for me.
Did the
So thank
insomnia
you.
predate the Ativan use? I hear your concerns about the benzos. So my recommendation is do not take them every night. I recommend taking only every other night, and then we will not refill it.
And so, what's diaphoresis?
Sweating.
Okay. And in the field of prescribing psychiatric medications, do you often have to deal with physical dependency and then addressing it later?
And what I do here,
I wouldn't say often.
tapping is
Is there a way to address that as far?
Absolutely, yeah.
And so,
and I would say don't give
that
up
wasn't a
on your
concern of
dreams,
yours
no matter
regarding
what.
Ativan, was it?
Not at that time.
And what about her statement about not being heard? Did you see that in her message, where she says, "I feel like I'm not being heard about
With that
addiction"?
being a possibility,
As a psychiatric nurse practitioner dealing in psychiatric medicine, is it important to you when a patient tells you that I don't feel I'm heard?
yes.
And do you take that in consideration when addressing them and continuing to build that relationship?
Yes.
And so in this case with the
On
defendant,
price,
with
I'm
Lindsay
going to
Clancey,
my implant was,
did that change your approach with her
and
at
the
all?
surgery was probably around $200,000.
It's why I sent the message that I did, trying to
That's
explain
so cute,
what
Lorraine.
addiction
Thank
versus dependence
you.
and tolerance is. And I wanted
Thank
to
you.
reassure her that we will try to have you take
I'm
these
char-
less
I'm charging
frequently,
you,
and
Carrie.
we don't need to continue them moving forward.
So she
You
advocated
just
for
call us
herself,
the
and you took that into
Energizer Bunny.
consideration and created an alternative plan, or
I'm
suggested
either
an
charging
alternative
my
plan.
phone,
Yes.
my back, my iPad,
Did your
my
care of her
laptop,
change at all
my,
when she told
you
you
know,
she wasn't being heard?
something's always charging around here.
I wouldn't say it changed.
Sometimes all at the same
Treated her
time.
as you would any other patient, right?
Correct.
Now, you continued to have messages with her throughout that day. Is that fair to say?
Yes.
And so at 10:02, you receive a message from her. Says the insomnia started from the Zoloft, but then after the 2 weeks of daily Ativan and Benadryl use, that's when the insomnia was at its worst. I've tried so many different sleeping aids at this point, trazodone, Ambien, Remeron, Seroquel, and they all seem to barely touch the sleep until I take Ativan with them. So tonight I will try 15 of Remeron with 50 of Seroquel. I fear that if I wake up in the middle of the night with intrusive thoughts again, I will feel like I need Ativan. Do you recall her sending that message at 10:02?
I do.
And that she
I've never
sends
heard of
another
so many
message,
doctors.
kind of cut off,
And
but
so
it's
many
still within the
doctors
10 o'clock hour,
like it's
where she
marvelous.
adds, I also just feel
Like I'm so
I also
lost
just feel
in the
concerningly
translation
numb right
now.
now. Like I have no emotion whatsoever. I feel like I'm going to
Did
die and I
Lindsay
don't
go
care.
to
What do I do
all
about
of these
this?
different doctors? How did she get so
I do
many
recall that
different?
message, yes.
And this is a message that she sent when she would have been or have seen Letitia Dukes already, right? If she had a 9 o'clock appointment.
Yes.
When she sent that message to you, did you respond back to her at 11:35?
I did.
And with the fact that she talked about being numb and having no emotions, feel like I'm going to die and don't care, what did you do?
I said, this sounds like depression and anhedonia symptoms. I would say if you're feeling unsafe, particularly as we head into the weekend, it is important for you to have information for psych emergency services available to you. And I provided a list of the 24-hour emergency service
here's my
programs like
experience.
mobile crisis intervention.
Do I know that you have to have a number of
And
doctors?
when you say
I've got one for every organ.
anhedonia,
Okay.
excuse me if I mispronounced
I got
that.
heart
What does that mean?
issues.
Anhedonia is a symptom of depression where people are unable to feel
I have
pleasure.
kidney
They describe it as
disease.
feeling numb. They're unable
I
to
got
look
one of
forward to
them.
things.
And in
My
her message
primary
where she
care
says, I feel like
doctor,
I'm going to
who has
die
to
and I
deal
don't
with
care. Did you
everybody.
take that as a
I've got
suicidal thought
pulmonary
or suicidal
sarcoidosis.
ideation?
So I have
And so did you tell her to go to the ER
one
right away?
doctor.
No.
Listen. Thank you.
Did you have
for it.
concerns
Thank
that
you.
she needed
But
to
you know what
get
I did? I'm going
a higher level of care at that
Let me
moment
tell
when
you,
she sent that message?
I'm legally
My
disabled.
concern about that
okay?
statement was
As
that I
legally
wanted
as
her to
you
have
possibly
access
get.
to resources
And
if it escalated
so
or
what I
if
did
she
to keep
if it
everybody
worsened.
straight
So I
with
made sure
each
she had it.
other
Okay.
is I
And
got all of the same doctors under the same roof.
fair to
We
say
have a
you
medical
also, at the end of that
center
message, indicate,
that has
are you
all
able
of
to get
those
rest or reach
doctors
out
under
to your
one roof.
support system so that you can be
So if there's a
helpful, so they
question
can be
about
helpful to you right now,
medicine
and
or
that this
who
is
I've
hugely
seen
important.
or what
I
I've
did say
done,
that, yes.
it's a
And 11:41 a.m. she
it's a
responds,
look
yes,
it
I have
up on the
support. My parents
computer.
are here to help.
Oh, I
And
see
again,
you were
this is
just over at
12:02.
Dr. So-and-so.
Does this sound like side
Did he
effects
give
to
you a
Remeron or
prescription?
Seroquel?
Okay,
I've
he
never
did.
felt like
I can
anything.
see the result.
I have
Oh,
never
we
felt
need you to
anything
run
like this
down to the
before.
lab to get blood work.
And then 11:57, she sends another
Oh, and then
message. Do you think
Dr.
over
So-and-so.
time these
Oh,
symptoms
did you
will
get?
go away
Oh, I
over
see here that
time?
you've done blood work with your primary. And
12:04, another
da-da-da-da-da.
message from her.
Everybody
Is
can
there
see
any chance
everybody
you could give
else's
me a call
notes
to discuss when you have a
and
minute?
what medicine I'm
At
on.
12:10
There's
p.m.
no
And
dang
just to
way
confirm,
that
your
I could keep up
recommendation for
with it all.
tonight is 15 Remeron,
How
50
did
Seroquel, and avoid
Lindsay keep up
Ativan,
with it?
even if I'm not
No,
sleeping.
I don't know if she did.
So you
I
got
don't know if
those
she could.
messages in succession, right?
I did.
And were you able to eventually respond to her with a phone call?
I responded to the message at 12 p.m. I wrote it down for her.
And again,
more.
in your response to her, did you reiterate that these are pretty common
But I do feel it. Feels
signs
roller
of depression, and that what she was expressing to you wasn't uncommon in women with postpartum depression?
Correct. I said it sounds more like depression than side effects.
They thought I
It's
had
not
diagnosed
uncommon for me to
and
hear.
I-
I've
well,
never
you're gonna
felt
have to
anything
do an
like this
internal
before,
echo.
or I just don't feel like myself.
Because they had
All of
done
this
echoes
sounds
and
like
it come back
postpartum
like that.
depression.
And then
And did you further
internal
try to give her
echo
some
and found out
encouraging
that my
words?
leaflets are torn.
I shared a
I'm a
passage
hot
from
mess.
a book
Don't
called
mess
This Isn't
with
What I
me.
Expected.
My medical records are longer than
And is that
CVS
book
receipts.
kind of centered around postpartum depression?
Yes.
And did you also tell her this is going to get better?
I said, even though they feel terrible, remember that they're symptoms of an illness that is
Hysterectomy.
very real and very treatable. This is going to get better.
Hysterectomy when I turned 40 because
And
Aunt tried to freaking
after
kill
that
me.
message on
I had to
12:12,
end up
did you in
having
fact
some
send her
blood
another
transfusions.
message?
I did.
And fair to say that next message was
I've had
to kind of
stuff
address the
taken
concern
out.
about
I've
her
had
question
stuff
what
put
to
in.
take.
Yes.
and you confirmed to take 15 milligrams Remeron, 10 milligrams Prozac, and 50 milligrams Seroquel,
Yes.
and that taking Ativan every other day might help.
I said, I would say taking Ativan every other day might help you to see you're not addicted, as
The
one cannot
point
be
is, how did
addicted to
you keep
something
up
they
with all
don't
this?
take every day. But we can also decide to let me be concerned about whether you have a problem with the Ativan and simply take it nightly for now. And if I have concerns about your use of it, I will make them apparent to you. My primary concern at this time is that you sleep. And if that means taking the Ativan for middle of the night wake ups, that is what it means. I'm confident we can safely and successfully get you off Ativan in the near future. And then I also go on to make recommendations about if she does have trouble in the middle of the night, certain sleep hygiene techniques that she could do, like getting out of bed, and doing something non-stimulating, and then go back down to try to sleep again when you feel drowsy.
So an alternative as to medication intervention.
Yeah.
And then at 1:40 p.m., she responds, "Thank you. I'll stick with that plan. I really hope it works and to feel like myself soon." Right?
Yes.
And then at 2:35, you respond, we will follow you closely. We have lots of alternatives. If this for some reason isn't the combination, we'll find one that gets you back to feeling like
Different
yourself.
things work for
I did
different
say that,
folks,
yes.
Lorraine.
In all your treatment
We're
of
on
women,
I'm on
the women
Indian,
that you've treated with postpartum depression,
and so it's just finding what works for you.
is this common that you
But
have
my
to
only
kind of
concern
trial
here
different
is I don't know that she gave
plans in order to find the
any
right
one
one?
thing a
Yes.
considerably what would
Okay,
you
it's
would
11
consider a
o'clock. Why don't
full
we
chance.
take the morning recess at this time? All right.
Thank you.
So they are going to
We'll take the
recess.
break.
That so 10, 11, an hour and a half. So probably 15. I don't know how long they take for recess, but mhm. I just don't know if they could. Yeah, it's a lot. I had to get a calendar when I first got sick and start keeping up with, because I mean I just nearly fell off the earth. I'm just telling you, it was horrible. Oh my goodness. So the jury's exiting, and what do you guys think so far? This
Anything
is
we need to
obviously a nurse
discuss, before the
practitioner
break?
that was seen before
All right,
Dr.
so we'll
Tess.
be in recess for the morning recess at this time.
But do you really believe that postpartum psychosis can lead to murder? It sounds like, I'm going to tell you, if this had happened 100 years ago, they would be doing a exorcism on Lindsay Clancey. But do you know what I'm saying? I'm not sure that they would have fell for this 100 years ago. And I think that a lot of people aren't falling for it now because they don't understand it. I don't know. I'm not claiming either way. I'm just saying why. I know, Brittany, I saw it, and I don't open them until I'm ready to mail it so that I can keep up with who I owe what. So I saw your message, but I didn't open it so I can keep track of it, if that makes sense. Survivor from what? I don't know. I don't know that. I did have a good weekend. Hope you did too. It's busy as usual. Busy as usual. Oh. Avoidant personality disorder. Oh. Hmm. You know, I don't think Patrick is a good person, but I don't believe he done it either. We have 461 souls in here. If you are in here, please give me a follow. It's totally free to do. Just hit that button right by my name right there. That way you can keep up with this case and all things true crime. I agree, Glass. Do I think that he was a loser? Yes, I do. as far as like his attentive to the situation, the fact that he's leaving her with the kids to run and get food, even after she said that she's having these thoughts. Yes, of course. You're saying except us survivors. How do you know I'm not a survivor of something? Just saying. But do I think he is a loser? Yes. Do I think that he done this to his kids and pushed her out of the window? No. I'm saying he sucked as a person, but he didn't physically do these things. People are trying to put different shoes on him. It's ridiculous. Missy, don't, I'm sorry for your trauma, but don't come in here comparing your trauma to my trauma. It's apples and oranges. Sorry for whatever you went through, but I don't understand what your point is. Dr. Many, do you think too many? How did this happen? How did so many doctors get involved? What's up, Banks? Thank you guys for your follow. Today's live goal is hand hearts. We have 2 of the 10. If you can throw one, it goes to support the platform. If you can't, tapping is clapping is free. Also, the gift gallery is open. Totally open. Oh my, I better get that down. Hold on. Totally open if you want to fill up something there. Again, that goes to support the creators who bring you this content on a daily basis. Thank you, just being in the moment. Thank you so very much. So you think good morning, Main Star. I love your name. Angela with the Barrel of Reefs is in the house. So you mean that people didn't help her? Who? Who's Pat? Oh, Patrick. All I could think of was Pat from Saturday Night Live. I'm not feeling it. I'm not feeling it. It's Pat. So my thoughts on the nurse practitioner that was just on the stand, way more detailed than the doctor psychiatrist. 3 days, Megan? I usually have a answer the next day. Mm. Well, I guess we can go over and check in on the Tupac. Tupac's finally getting justice after 30 years. Do we know where we at on that? Did they pick a jury yesterday? So CNN is live, but they're not from the scene. And I don't know how long this Tupac Shakur trial is going to last. I can't see that they're live in the courtroom. Angela says, I think Remington will have a harder time shaking her. Oh, the nurse practitioner. I don't understand all of the doctors. How many? Okay, I'm going to have AI help me with this. Hopefully it's going to be right. She had three psychiatrists, which was Dr. Tufts, Dr. Alea Goodhart, who treated her during a 5-day voluntary stay at McLean Hospital, 2 psychiatric nurse practitioners, which one of them you saw on the stand, 1 medical doctor, therapist. So is that the norm? 3 psychiatrists, 2 psychiatric nurse practitioners, and 1 medical doctor. What can the other 2 psychiatrists do that the first one couldn't? Maybe she's wanting a second and third opinion. Let me see the timeline. Not at the same time. Her treatment followed a sequential timeline across the 4 months following the birth of her 3rd child, where she was shifted from one clinician or facility to another. In May 2022, she gave birth to Callan. And then in September of 2022, her mental health began to decline. So at that time, in September of 2022, she saw outpatient care and was initially treated for postpartum depression and severe anxiety. Her initial outpatient providers adjusted several medications like Prozac and Zoloft to manage her symptoms. So September is when she started seeking that type of help. November the 30th, 2022, her first psychiatrist, Dr. Paul, transferred her outpatient care to a new provider because she was relocating out of state. In December 2022, she began regular telehealth vision evaluations with Dr. Tufts, who we saw yesterday. During this time, she also saw psychiatric nurse practitioners. And this is when her medication frequently changed as she reported these side effects that Dr. Jennifer didn't write down, as far as I'm concerned. January the 1st through the 5th, 2023, she had several thoughts, intrusive. Clancy checked herself into McLean Hospital for a 5-day voluntary inpatient stay. While there, her care was managed by inpatient psychiatrist Dr. Alea Goodhart, who discharged her after determining she was safe and not showing active signs of psychosis. January the 6th through the 23rd, 2023, she returned home and resumed outpatient telehealth care with Dr. Tufts. January 23rd, Dr. Tufts increased her antidepressant medication. January the 24th, the very next day, all of the stuff happened with the kids. Honestly, the average stay is 3 to 5 days, I think. I mean, I don't know. This is a lot to have happened here in the span of time. You're talking from September to January, which is not a long time. There's a lot of doctors, a lot of diagnoses, a lot of medications. That is true. I know that to be true. Well, it's usually at least 3 days. Yeah. So You know, I have to say, yesterday was a total 1000% win for the defense, because if you're going to establish misuse of medication, um, then he done it yesterday. Side by. Monica needs a side by. I'd say if you're on 13 different medications, you have a pretty good chance of losing your ever loving mind. Does it lead to or justify the unaliving of 3 children? Boy, this jury has a hard road ahead of them to sit down and try to think about who. Listen, everybody coming in here saying Patrick did it, yins better be careful. Patrick went and got himself a lawyer, so he knows y'all been talking about that. I'd be careful. I mean, I'm just saying, I think he had a part in her mental psyche, but I don't think he physically done it. Remember, you can't state something as a fact. If you do and it didn't happen, that's called slander. And he's got the money. We know he's got the money. $1 million plus. That's what I was thinking, Jess, but I heard through another outlet that he had obtained a new kind of attorney, so we'll see. Prairie, yes, of course. He shouldn't have left her alone. That was the stupidest thing he's ever done in his life. Len, we've talked about this before. You tell me you're thinking about offing my children. Me and the children are out of the house. Capiche? I'm not leaving them with you so that I can go get food. So, because he's a horrible father. I mean, he's a horrible person. You're asking me if I like Patrick Clancey? No. I don't like him. He's shady as hell. But he didn't physically do this. Now, did he leave hoping she'd do it? No, we don't know, really. 547 souls in this room right now. If you're in here, please give me a follow. Totally free to do. Just hit that right by my name right there. Totally free. That way you can keep up with this crime and true crime all the time. Do I think the defense has done their job so far? I do. Thank you for your follows and your heart me's. Thank you. I appreciate all that. Yep. I don't know how long the break is. I can go check for you, or somebody can just let me know. They're still on break. I can still see the seal. Back Porch Confessions. You hadn't followed me yet, or I'm just making sure you're you. We don't want impersonators in here. Oh, you reset? Oh, thank you. Autumn says the jury will struggle with the timing of her psychosis confidentially happening when Patrick left. Oh, coincidentally. Honey, I can't see. I'm owed. He's 75. I hope I'm throwing down when I'm 75. It gives me hope to know that I could last another 30 years throwing down. Yeah. Did he though? Did he? Thank you for the cows and the hearts. Thank you. I appreciate you, back porch. Did he change clothes? No. No, he didn't. Silly Willie. Don't be so silly. Silly Willie. That's what I'm hearing on the shoes, but I don't see it. I don't see it. I don't see it. I've clothes now too. Thank you, back porch. But is there video? Okay, listen, before I spaz out here. Listen, Linda, listen. So the investigators investigated the investigation. And you're telling me that they pulled all this video of Patrick in the CVS and all the whatnots, and no outside cameras got him a better view to where the investigators could determine that he not only changed shoes, but changed clothes. And no investigators, nobody, only the court of public opinion has come up with this. No investigators, nothing, none of that. Good morning, Kelly. I just can't. But then also, why would she sit there and be like, okay, so yeah, I'm going to go take the fall for this. And then Patrick done it? Oh my God, Daisy. Thank you. Yes. Go find Nancy. Stop looking at shoes. Tori says there's too many holes in unanswered questions. There's something. Probably a couple more weeks at least. 549 souls. Today's live goal is these hand hearts. We have 4 of the 10. If you can send a hand heart, and then 6 of you in here send 1 hand heart, then we reach the goal. It's as simple as that. Everybody gives one thing, and all of those individual things add up to the one thing that keeps this platform going. Thank you, Tanks. Thank you, Prairie. I saw you. Thank you. Only a few more. And the gift gallery's open. Hollywood says he did it. Oh, come on. First of all, let me go see. The video. We're going to watch. Is there a place where you can just watch the video? Because I'm going to pull that up if there is. Okay, Vinnie Politan talked about this. Vinnie Politan. Do you guys remember when I was on Vinnie Politan's show? He has his own, like now, Vinnie Live. I've met Vinnie Politan when I was covering Karen Reed. He's a nice guy. I like being on the show with him. And so if you have YouTube. Come over right now. I'm on YouTube at Steph's Case File. There's 500 people in here. Come over here and watch this surveillance video with me. I want you to show me the outfit and shoe changes that Patrick Clancy allegedly did. Come over, Steph's Case Files. I know everybody in here got YouTube. Everybody in here has YouTube at Steph's Case Files. Come over. We're going to watch it together. I want to hear what Vinny Politan has to say about this.
The internet's on fire. Patrick Clancy's got a secret double life.
I don't have.
Patrick Clancy, not Lindsay. Patrick Clancy is the one
I got it.
responsible. This is an unbelievable development in what people are saying, what people are talking about. Did not expect this. This came out of like left field for me.
Me too, Vinny Politan.
Patrick Clancy's connection, responsibility for what happened to his children. Not like he should have done more to help his wife. No, more like he had a double life, didn't want his wife, didn't want his kids, and got rid of them all. That's what we're talking about. That's what we're going to talk about in this video. Because the internet has gone bonkers on this.
Yes,
like blowing up.
Dan.
And I'm trying to figure it out. All day long, I've been digging deep, trying to figure out what is the basis of all of this.
Me too.
So we're going to talk about it. We'll talk about everything from the timeline to the shoes. As we take a look at Patrick Clancy, not Lindsay Clancey, Patrick Clancy, the evidence, the skeptics, the allegations, and is there anything to back this up? I'm Vinny Politan. It's Sunday. Thank you so much for joining me.
I've not seen this yet.
We've got another big week coming up on Court TV on this case against Lindsay Clancey. But here in this video, we're going to talk about Patrick Clancy.
How did she done it?
This is Vinny Live.
How did she done it? Isn't that enough? We're watching Vinny Politan, my buddy. Vinny Politan, over on the big watch. Come over.
Streaming live.
We're going to watch his show and see what he has to say about
Vinny Live. It's true crime. Streaming live. Worldwide, it's Vinny Live. Get ready to post inside the chat. Get ready for the prosecutor hat.
when do I get my own jingle?
To like and to subscribe. Get ready, it's time for Vinny Live.
Come on, do it, Vinny.
Fasten your seatbelts. We're going there. We're going to go there. I'll go there. Why not go there tonight? let's just do it. I mean, I'm surprised.
Suno, Mary. Suno.
At times I was baffled, but then I started digging in to figure out what people were talking about. Because
we'll get flagged. You got to
let me just start with this premise, okay? The premise of Patrick Clancy's involvement is that neither the prosecution nor the defense is talking about that. The prosecution nor the defense. And why is that important?
Because it didn't happen.
Why is that important?
Because it didn't happen.
Kevin Reddington, you've been watching him. I told you about it. I was telling you for months leading up to this trial about her lawyer, Kevin Reddington, and how good he is, how thorough he is, and how persuasive he can be. and how on point, how he takes control of the courtroom, et cetera, et cetera, et cetera. If there was evidence that Lindsay didn't actually do it, do you think that they would be relying upon the hope of a not guilty because of a lack of criminal responsibility with NCR, which doesn't set her free initially, confines her until she's no longer a danger to herself or to others? But it's a defense that runs many risks with it, because the first thing you have to do when you claim that is basically admit that you did it.
Yes.
The lack of criminal responsibility is not saying you're not responsible for the act, but you're not criminally responsible for the act because of your mens rea, your state of mind. So this is a big premise you have to think about when you're thinking about the things we're going to talk about here. It's like, if there was a there, why wouldn't Kevin Reddington go there of all defense attorneys?
Exactly. Vinny,
With that much experience and that smart and the ability to find reasonable doubt wherever it lurks.
Oh my God.
This is not the Karen Reed case. There's no alternative theory inside the courtroom bubbling up with the people involved that anyone other than Lindsay Clancey actually did what caused the death of her 3 children. Now, there could be arguments about the treatment, the medications, should he have left the house, like all of that. Yes, you can talk about that.
Is it echoing for anybody?
But nowhere, anywhere have I seen inside that courtroom anything about her not doing it, committing the act. It's not there. If there was evidence there, wouldn't Kevin Reddington take advantage of it? Of course he would, because he has for decades and decades in criminal courtrooms all across the state of Massachusetts. But he hasn't. Now, the other thing is, once we dive into these, again, we're going to dive into these theories and the skeptics, etc. There's not going to be evidence in this trial to refute any of this, because neither side is alleging any of this. This is another big premise you have to understand. That if someone was alleging, like the defense was alleging that Patrick was the one responsible, then prosecutors would put in more evidence to demonstrate that he didn't do it. But they're not doing that. So all these pieces, Apple Watch, shoes, timeline, etc. If there were some questions or some problems, there would be more evidence about it to demonstrate that it's not plausible. But you're not going to see that evidence. And I don't want you to take the fact that you're not seeing that evidence, that the evidence doesn't exist. It's just no one needs that evidence, because neither the prosecution nor the defense is saying that Patrick did it, is saying anything other than, yes, Lindsay did it.
Thank you for the follow.
But the question is, was she or was she not mentally ill? Was it the mental illness that caused it, or was it Lindsay that caused it? Lindsay's mental illness. It's not gonna be there. It's not gonna happen. It has not been part of any of the pretrial litigation leading up to this. It was not part of any opening statement, which is the roadmap of the case. None of that
You can email from your phone.
exists. And some of these things, which are sort of simmering and bubbling, could be potentially disproved, but won't be in this trial because it's not an issue. So those are two big premises that you have to understand. And it makes a lot of this, puts it in a very different place than when, for instance, the Karen Reed trial, when you were talking about people inside the house, 34 Fairview, and you didn't see evidence, but you saw something, but you didn't see anything to refute it, then, it made sense because no one was conceding that Karen Reed was responsible. Quite the opposite. But that's not this case. That's not this trial.
Can you bug in, please?
Thank you. Nurse Gelato, when we broke, we were talking about your interactions via my chart with Lindsay Clancey on December 2nd of 2022.
I was
right?
saying that
Yes.
And so
you referred
the
to the
last
Republican. You
one
referred to
on
the
December 2nd at 2:35
We
p.m.
are
was
back in the trial.
from
The trial is
you
back.
to her.
He's not falling
And then
for it,
on
neither
December
am I.
3rd, do you recall
You gotta let it go. You
that
gotta
my
let it
chart
go.
message was sent
Because
from
if
that
you're
day at
Reddington,
7:24
anybody
p.m.
in the world,
and you were able to review that message
anybody, and he's right,
after some
that
point
could
after
have
it was
found
sent.
that somebody done it
was.
other than Lindsay
And
Clancey
she
Reddington
reports to you
would have it
basically
in his
she
hand.
didn't want to wait to let you know some things that
You
were
want to
fresh in her
say how
mind.
good
And it
he
says,
is,
last night
but
I
you
didn't
want
take
to
Ativan.
insult
My
him.
dose had been the night
Or
before
missing
at
who
1
actually
a.m.
done the
Only
murder.
slept about 4 hours at the
Can't
beginning
have
of
it
the
both ways.
night, about 9:30 to 1:45. Then I dozed off for maybe another 45 minutes from 4:30 to 5. Today, all day, I had horrible, intrusive thoughts and felt deeply depressed. I finally took a 0.5 of Ativan at 6 p.m. and now the thoughts are gone and I feel good. You recall receiving that message?
I do.
Okay. And fair to say there was no more communication between you and her until December 6th.
Correct. I believe
Two more
December
hearts.
3rd was a Saturday.
People.
And you actually were out of the office on the 5th with sickness.
I was.
But you were aware that Lindsay Clancey did reach out to the office on December 5th.
Yes.
And that the nurse was able to respond to her to let her know that you were out sick, right?
Yes.
And Lindsay Clancey responds at 8:30 a.m. that day that
He didn't do it.
that she would just reschedule. Lindsay reaches out to the nurse and says that's fine, she'll reschedule, and that she in fact changed her appointment with Letitia Dukes to a virtual appointment for that day for December 5th.
Yes.
So on the 6th, when you return, did you have a scheduled meeting with Lindsay Clancey?
Yes.
And on this particular meeting on December 6th of 2022, do you recall if that was an in-person or a virtual visit?
It was an office visit
Okay.
in person.
And so just kind of looking at the note from that day, from December 6th,
Mm-hmm.
it says encounter date December 6th. It says filed on December 7th. In the under chief complaint history, do you have it in front of you?
Yes.
The second paragraph says patient has verbally consented to this video visit. Is that just something that sometimes pre-fills into the narrative?
Yes.
But your memory was that this was an in-person visit.
It was.
Was Lindsay Clancey there by herself or with somebody else?
She brought in her husband, Patrick.
Had you met him before?
I had not.
Had you talked to him before?
I had not.
As part of your treatment plan or your course of treatment with Lindsay Clancey, was it your practice to speak with collateral individuals?
Yes.
And in this instance, did you feel a need to speak to collateral individuals up to this point?
Not up to this point.
If you did, would you have requested that of her?
Yes,
And do you need her express permission to do that?
I do.
So on this particular day, she presented with her husband, Patrick, correct?
Correct.
And was there anything different about your approach to the meeting than your previous meetings with her?
No.
You still go through history, you go through how she's doing now, you do your mental status exam, you do your screenings, right?
Yes.
And so first, just let's talk quickly about the screenings. The Edinburgh screen, what was her score on this day when she came in? Do you remember?
21.
And the GAD-7, fair to say that screen was a 19.
Yes.
So would you say that it was pretty consistent with the last time that you saw her?
Objection.
What's your objection?
My objection is that that's not right. He's now got a 21 Edinburgh scale. Prior testimony was not anywhere near 21. It's deteriorated.
Well, I'm gonna allow that question. On cross-examination, you can certainly explore the basis of what her opinion was. So I'm gonna allow that question. Go ahead, Como.
Well, let me ask you about that score of 21. It's 21 out of how much?
30.
So in what range is that?
Moderate severe.
Okay. And on your previous encounter with her on, or your actual telehealth on November 29th, you reported that the score was 17 and that's moderate.
Moderate. Yep.
And then on the GAD-7, on this particular day on December 6th, it was 19, right?
Yes.
And on the previous visit, it was 14.
Yes.
Okay. So as far as your observations of her on December 6th, did you notice anything different about her speech and language?
No.
How about her mood? What did you note her mood to be?
Anxious.
And the affect, fair to say, consistent with mood, meaning anxious, right?
Yes.
And thought process.
Thought process was linear and goal directed.
And thought content, did she indicate to you whether she was experiencing any auditory or visual hallucinations?
No.
Any delusions?
No.
Any suicidal ideation, a plan, or intent?
No.
And as far as your observations of her during this interaction, this in-person visit, did you observe any signs of psychosis?
At Steph's case,
No.
Did you observe any signs of mania?
No.
Did you observe any signs of obsessive thoughts or compulsive behaviors?
No.
Now, when you met with Lindsay and Patrick on December 6th, did she or did they report why Patrick was there?
I don't recall if they indicated why he was there. I understood it to mean he was there to provide collateral and support for her.
Were you aware that he was coming to the appointment?
I don't recall if I was aware beforehand or not.
And you had engaged in a pretty significant my chart back and forth with her in the days preceding this this meeting on December 6th, right?
Yes.
Did she ever indicate to you Did she ever indicate to you in those messages that she wished to bring him along to one of the visits?
No.
Fair to say, when a person brings a collateral and is willing to have somebody speak, you're more than happy to get that information.
Absolutely.
This person, this collateral person, can they offer you a different perspective about the patient and what they're going through or what they're, how they're presenting?
Yes.
In this December 6th meeting or the visit, did she report to you some changes in her sleep or significant concern for sleep?
I would have to review the note. What I remember is that the sleep really hadn't improved much beyond getting a few hours, waking up in the middle of the night, maybe piecing together
Okay.
more time.
And fair to say, there was some conversation to go back and talk about when symptoms started and try to get to kind of the root cause or what they believe the root cause of her symptoms were.
Yes.
And did Lindsay and Patrick report to you the connection with the Zoloft medication in September as a concern?
Yes.
And that at that they reported that, or she reported that exact night I went from 25 to 50 milligrams. I didn't sleep for 48 hours and I wasn't tired.
Correct.
So that's in your note as a quote, meaning that's directly what she told you?
Yes.
Did you express to the Clancy on this particular meeting
Okay.
did you express to Ms. Clancy thoughts that you had about her diagnosis based on your interactions over the last few weeks?
I did.
And what was that?
I discussed with her and her husband the possibility of potentially an underlying bipolar disorder. I based this on several factors, one of them being that she had such what we call an activating response to the Zoloft. It's unusual for somebody to describe taking Zoloft and then going 48 hours without sleep and not being tired. So that raised my clinical suspicion a bit. And she had been, I would say, having difficulty tolerating other antidepressant medications that we had been trying to have her take since then. And so again, I'm wondering if it's because potentially there might be an underlying, what we call mood disorder, bipolar disorder.
And as far as the information that you had about her past psychiatric history, were there any indicators to you about manic episodes?
No. So I do recall in reviewing Julie's note prior to meeting with Lindsay, she filled out what we call a mood disorder questionnaire. It's like a screener somebody can do to assess history of mania and bipolar disorder. Lindsay it was a negative screen. So there's 3 questions. One question has 13 different symptoms. You have to score 7 out of 13 on question 1, but also in question 2, it asks about, are the symptoms happening at the same period of time? And then it asks about any functional impairment from the symptoms. So I recall the 3 symptoms she did endorse were not sleeping for that period of time with the Zoloft and not feeling tired, having racing thoughts, and trouble concentrating. None of the other symptoms did she endorse. They did occur at the same period of time. And I don't want to be inaccurate, so I can't remember what she said for functional impairment, but I believe it was minor impairment.
Okay, and so the fact that those were reported, but ultimately the full screen revealed negative for potential mania.
I did also consider, though, that the MDQ is less specific when it comes to bipolar 2 or bipolar not otherwise specified. There's bipolar 1 and bipolar 2. Both have mania symptoms as part of the diagnosis. Bipolar 1 is usually more severe in that it's typically, you know, a patient might be hospitalized or it causes greater functional impairment. Bipolar 2, it's a shorter duration and typically less functional impairment.
And as far as determining diagnostically whether somebody might be presenting with bipolar disorder, is there a particular tool you use in your trade to try to assess that?
Typically something like the MDQ, and then you'll do more of an interview asking the patient about symptoms specifically and if they can ever recall a time where this may have happened in the past, because sometimes
Ricky,
patients
as far
can't
as
always remember when they're
good at all?
manic. So I was glad to
Or-
actually have Patrick in the visit because he could sort of help us look at Lindsay's history more longitudinally, or at least since the time he knew her.
Okay. And as far as, so those tools that you're talking about, the MDQ and kind of screening tools that you use in practice, is there another tool that you use to assess whether a person meets particular criteria to be diagnosed with bipolar 1 or bipolar 2?
There are others, not ones that I've used.
So are you familiar with the DSM-5?
Oh, yes, yes.
Okay, so while that's not the end-all be-all, it is a guide that tells you specific criteria, how to determine if episodes are manic or depressive, right, when it comes to bipolar.
Yes.
The difference between mania and hypomania.
It's back.
Yes.
And so while you noted that there were some concerns reported, did what was reported to you rise to the level of diagnostic criteria for bipolar disorder?
Not at that time.
And when you explain this to them, your thoughts about her reactions to the medication and these reported prior symptoms, did Patrick and Lindsay seem receptive to your diagnosis?
I recall Patrick saying my wife is not bipolar. Lindsay looked at me. She did not say anything.
Okay. And was this the first time in this meeting on December 6th where you broached that issue or mentioned that?
Who is he?
Yes.
To be saying she's not bipolar.
Did the conversation continue about symptoms and managing symptoms after that?
Yes.
Were you able to get any more specific information from Patrick during that meeting? Not what he said particularly, but did you get additional specific information that kind of helped you assess whether you would change your diagnosis at that point?
No.
And were there still concerns in that particular meeting that the focus was trouble sleeping and the potential for addiction?
Yes.
As far as recommendations, did you talk about what's called tapering medication?
Yes.
And what were your recommendations regarding tapering?
So we talked about her concerns about the benzos. And we decided to come up with a plan to taper off of them.
And the last that had been reported to you via the MyChart messages was that she tried not taking it at
Ratings
all,
not even
ended up having horrible thoughts and felt deeply depressed, then took it and felt better.
Sorry.
So
Listen, though.
was it
He's not even
realistic
doctor.
to recommend completely stopping?
It seemed to
No.
me
So what
to
is
go okay
a taper? Like why do
with
why
Tufts
do you recommend
and
tapers?
date. Is it going to go okay with her
I
in
recommend
Redington?
tapers
This nurse
to
practitioner?
slowly get somebody off of something. And tapers can be useful because we might have somebody at a dose and they might say, oh, I'm too anxious to stop this, or I'm not ready to step down to another level, and we can kind of keep them on it longer. But at this point, since I had met her on November 29th and throughout the MyChart messages, there was
totally free to do right there.
multiple concerns voiced about benzodiazepines. And again, in this visit, so I even did what's called a CWA assessment, which is something we use to determine if somebody's having actual withdrawal from benzodiazepines or alcohol. Again, I really wanted to show her I was assessing this and taking this seriously.
When you say CUA assessment, is that an acronym for something?
Yes, so it's
What are the letters, just for the record?
CIWA. CIWA.
Okay. And did you, when you do that assessment, does it give you some sort of score?
It does.
Ask the questions. And what was her score when you did that CIWA assessment?
1.
And what does that mean?
Minimal to no withdrawal. The only symptoms she reported was anxiety. Her blood pressure was normal. Her pulse was normal. She had no nausea, no vomiting, no tremor, no tactile disturbances. People in withdrawal from benzos or alcohol will sometimes feel like there's bugs crawling or pins and needles. Auditory disturbances, so hearing things, seeing things. No sweats, no headache. She was oriented.
Okay. So with that, and knowing that she wasn't in withdrawals for Ativan, did you still recommend the taper and an alternative?
I did.
What was that?
I recommended Valium. The reason I recommended this is she had discussed rebound anxiety with me at our very first visit, feeling that rebound anxiety above her baseline once the benzo wears off. Valium has an extremely long half-life. It can, as in like 100 hours. It has a longer clinical duration of action. So I wanted to offset the chance that she would experience rebound anxiety. And it's often used when we're tapering somebody on shorter acting benzos. It's common practice to switch to longer acting benzos to do this.
And did you also have conversations about
Ask
the
your
other
girlfriend.
medications
Did
that
Lindsay
had
actually get
been at
any
issue, the
therapeutic services?
mirtazapine and the Seroquel?
Instead of just here, try
Yes.
this, try this. Did she
Did
actually get any
what did the
Working
defendant, what did Lindsay
therapy?
Clancey express to you as far as Seroquel? Did she want to continue with that?
No.
Did she explain why?
So she felt like when she took Remron and Seroquel together, she felt weighed down and exhausted, but her mind was still awake and alert. And she just didn't seem to think there was a benefit to being on it.
And so did she express to you a desire to want to go back to trialing Prozac?
Both Lindsay and her husband expressed that that was their preference.
And was that something that you agreed with?
I did. I had shared with them that I had concerns could be bipolar. It's my differential diagnosis, which is just all the typical diagnoses we might be considering. And that typically SSRIs are contraindicated, but she did have that history of being able to tolerate back at 20 milligrams and do okay with no mania. So that's what they were wanting to do. So we could do it. We could try it.
When you say contraindication,
Okay, sorry.
what does that mean?
It means typically not something you would want to do if you were sure somebody had bipolar disorder, because if you put somebody on just an SSRI or like Prozac,
Thank you for the
like
love.
Zoloft, it can create a scenario where people are flipping back and forth between manic symptoms and depressed symptoms, or they're called rapid cycling. It's not that antidepressants or SSRIs are never prescribed in bipolar disorder, but you often would want to have a mood stabilizer on board at the same time.
Dang, Gemma.
And so, despite your suspicions, you listened to the patient and went along with her request.
Yes.
So at the conclusion of that meeting, did you indicate that she could discontinue the Seroquel at that point
Yes.
with the plan that she was going to restart Prozac?
Yes.
Um,
Which I had been recommending the Prozac earlier, I believe, even on November 30th, I had recommended it.
and with that previous recommendation, it was in addition to the
Remeron.
Seroquel.
And the Remeron, yes.
Becky. Holy moly.
So after
Y'all
this
see that?
meeting,
Is it that it affects one person a different way than
on
the
December
other?
6th?
That's the question. Remember the controversial question I gave you on? I said, you're not going to like me. And I gave it to you some days ago. And I said, did it cure her?
Did you have additional
Oh,
communications
I can
with
feel the
Lindsay
ice in
Clancy via the
Oh,
MyChart
good
messaging
God,
on
honey.
December
You
7th?
know where I'm going with it.
Yes.
And fair to say that those communications started as early as 9:48 a.m. when she sent the first message, right?
Let me just make sure.
$31,000 likes. I'm going to challenge you guys to get to 50,000 likes. Tapping. Send me your heart, baby.
Oh, yes.
We got 400
Yes.
souls in here.
So on December 7th at 9:48 a.m., she sends a message saying, "Hi, Rebecca. Last night did not
And I
go
was
well
talking about in the sense of
at
the
all. I
itch
took
murder.
the Valium melatonin and slept only slept from 9 to 1. Then around 2, I got desperate and took 25 milligrams of Benadryl and only slept about 1 more hour. What can I do? I really need help." So that was the message that you came into on December 7th, right?
Yes,
And did you respond to her in the messaging app?
I did.
And what was the response?
I'm trying to find the sequence.
Yeah, 10:19 a.m.
I think it's cut off.
Yeah, no. Was it a cure for the itch
Okay.
to murder?
So
Keep that in mind.
I
You're going to have to
discussed,
think that question.
I mentioned, so your husband made a good point yesterday. Despite taking the Ativan in the evening, you were still only able to get a 5-hour stretch of sleep, which, yes, is improvement, but does sort of dispel the notion that benzodiazepines are the only thing that are helping you sleep right now, as you are still getting less than the target of 6 to 8 hours with Ativan, and the Valium did not help for sleep much at all. My next step in this case is to try a higher dose of Seroquel on its own. Are you feeling any subsequent loss of energy, exhaustion, fatigue with lack of sleep?
Why would it be the next step to increase from 75 of Seroquel to 100?
So she had been taking 50. So I was suggesting 75 to 100 would be my next step. Because again, bipolar is still on my differentials, and now I have the data that she only slept 2 hours. So I asked her the follow-up question, are you feeling tired? Or, are you feeling exhausted? Any subsequent loss of energy? It's still in the back of my mind that this could be bipolar.
Could it
So
cure
as far
her?
as
There
the
is no
Seroquel goes at that
I
point,
have depression.
creeping up
Oh,
the
no.
dosage, do you get now from the using it to treat
My
insomnia to using it
question
to
is,
treat something
we
else like
rephrase it,
bipolar?
so
Correct.
And so
Becky here
that piece of
pretty
it
much,
about feeling subsequent
on
loss
a
of
lot
energy and
stuff,
exhaustion,
right?
fatigue.
That
Why
either,
ask that?
and I know it
Patients
affects
can
people differently.
have insomnia
The same
because they're
medicine that
anxious or
Lindsay has
because
for
they're depressed,
cough,
but
and she's saying, but I
typically
never wanted to
they're
murder anybody.
exhausted or they're
And I know
tired the
it's
next
rare.
day, and it really does affect them.
And I know
If
medicine
a patient
makes
has an
people do
underlying
strange things. My
bipolar,
question to you
they could
is, did
go
it
on 2 hours
cure
of sleep and
her
not feel tired at all, and that's unusual.
notion to
And
murder?
so that is one of the signs potentially of a manic episode.
Potentially, yes.
So on December 7th at 10:33, she responds, "No, the weird thing is I don't feel tired at all." And she says, "So just Seroquel tonight, ? I feel like I'm going to panic without a benzo with it." And then again at 11:44, another message, "Would I be able to do the Valium with Seroquel? Is that a safe option?" So again, in this exchange with her in MyChart, she's asking you questions to clarify what you've said and also alternatives to address the issue, right?
Right.
And as far as her questions go, and then her response about not feeling tired, how did you respond in the message?
So she kind of sent those in succession. So I don't feel tired. Would I be able to do the Valium with the Seroquel? So I respond by, if you're not sleeping well with the Valium alone, there's no need to continue it. And I will prescribe a short taper to get you off benzos altogether. Because you are not tired at all and had a significant reaction to Zoloft at 50 milligrams, I'm concerned this is an underlying mood and bipolar disorder. I know you and your husband did not necessarily agree with that.
No,
but I feel that I'm going to send along this
no.
information to review. So I sent her
We went
a list
Two
of
different
symptoms
shoes
of
at
bipolar
CVS.
risk factors.
Now he's changed outfits at
so
CVS.
that she could have
and
it
now
to
there's
refer
a second
to.
man involved.
And again, at this point, the only symptom she was reporting of mania
You
was
serious
this
as
not being
this.
able to sleep and not feeling tired, right?
And yes, and the racing thoughts and the trouble concentrating.
Okay, is that things that she had reported to you in your visit on the 6th?
No.
Okay. In these messages that she was sending to you in her on December 7th, she didn't talk about racing thoughts, did she?
I'm trying so hard.
Okay, she just talked about the sleep.
Mm-hmm.
Okay. But based on a review of her history, she had at one point indicated that she was feeling those in relation to a symptom she was describing. Is that
correct?
So at this point, what do you recommend her to do?
I explained the importance of knowing if this is bipolar is significant because SSRIs like Zoloft and even Prozac would be contraindicated. My recommendation is to do 100 milligrams of Seroquel tonight, 200 milligrams of Seroquel tomorrow night, 300 milligrams on 12/9, 400 on 12/10, and we will hold there. I actually say hold the Prozac as I'm concerned this is a hypomanic mixed manic state.
And what about the Remeron at that point? Where did this fall into the mix, if it fell in at all?
I had recommended a very short taper on December 6th.
Don't
I think
get
I
in the
advised her to
super chats
take
over on YouTube.
half of a 7.5 milligram tablet for 3 nights, but
Super chat.
in her message to me on December 7th, she had not taken it that night. So I had assumed she had just stopped that entirely.
Okay.
What's up, Cade? Is that your full name? I love
Now,
that.
after you sent that message at 12:32, did she respond at 2:53, indicating that she would stick with that plan and that she said
Ooh
she
la
needed a
la.
refill on the Seroquel
I had a
because
grandmother.
she only had 30 25 milligram tablets?
There were actually, she did say
Great,
that.
great,
There were
There's a
actually a
long-ass
few
time ago.
earlier
I got a
messages
little
as
friend.
well that day. I provided an alternative. One as an option, it quickly came into my mind. Oh, we're thinking about Prozac. We could add Zyprexa on board because there's actually a combination pill of Prozac, Zyprexa. The brand name is Symbyax, and it's for bipolar.
Not.
And I said, for our purposes, we can prescribe them separately and take them both for the same effect. And I asked her to let me know which one she would prefer. And she responded, I think I would like to do the Seroquel with the Valium taper.
Okay, so that suggested alternative actually was on at 12:37.
Correct.
And then at 1 o'clock, she elects that she'd like to do the Seroquel with the Valium and asks for you to call in the Valium and the Seroquel.
Yes.
So that's on December 7th, right?
Yes.
On December 8th, at 6:35 a.m., she sends you a message saying, did well last night, need Valium,
This is
feeling
part
panicky,
of my
don't
DNA
know
that's
if ready to
on
taper as
there.
quickly as planned.
Yes.
Kind of paraphrasing,
This is
but
this
Yeah,
is
she
Cade. This is
exclaimed,
where
I actually did really
Franck-
well last night with the Valium
I
and
don't know where
Seroquel. I
Brittany
mostly slept
Franck
from 9 to
is, but I want
5
to go there. That's
with
where
a
my
few
ancestors
wake
are
ups,
from.
but was able to go back to sleep. She was concerned that she felt like she needed to take the Valium around 5 p.m. because she was feeling panicky. I feel really dependent on it. Can I taper any slower?
Cade, are we
And what was your
cousins?
response to her request for a slower taper?
I said I'm hesitant to
Cade,
taper any
no freaking
slower.
way.
Remember, Valium
I
has a
can't
really
believe it.
long
We're
half-life,
probably
100
related.
hours, so you will have some on board in your system throughout the weekend.
And why were you hesitant to taper any slower?
I felt like she was anxious about being dependent on it, and so I was trying to facilitate the process of tapering her off, and I was clinically thinking we could cover her symptoms of anxiety as we titrated the Seroquel, because Seroquel actually has several clinical trials that show it has really good efficacy for anxiety.
And this conversation about the request to taper, that actually goes into December 9th of 2022, correct?
Yes.
And in her response to your indicating you were hesitant to taper, she indicates that she took the 5 milligrams of Valium and that she didn't have any left, and that she was afraid that she was going to take Ativan.
Correct.
And had you recommended to take Ativan as an alternative or in lieu of Valium?
No.
Were there any more communications on that December 9th of 2022?
Yes.
Same thing with
What
me.
were they?
I have
Later that afternoon,
and I only take very,
Lindsay
very
and her
rarely.
husband called.
Very rarely.
And so did you,
When I can't
fair to say they
get
called the
my
clinic,
anxiety
leave a
under
message,
control.
and then you
And
called them
because
back?
it makes me feel
Yes.
like that. It makes me
And
feel like I just want to lay
when
down
you
and
called
sleep,
them
and I don't
back,
want to
what
do
was
that. I want to live
the
my life.
nature of that
I
conversation?
don't
What
deal
did
with
you
the
guys talk
Seroquel unless I
Her
absolutely need it.
symptoms, we discussed that the plan was to taper the Valium over the weekend, but they both agreed that Lindsay's symptoms were too acute. She's sleeping better, but still waking up with panic symptoms and intrusive thoughts, feels numb, has thoughts of SI, but no plan and no intent. I encouraged her to engage with women and infants in Rhode Island to complete an intake for a partial hospitalization program. But she was able to contract for safety over the phone with her, with the 3 of us on the phone, that she didn't have a plan, no intent, that she would reach out if needed. I did agree to continue the Valium until our next appointment, which was scheduled for 12/13. I prescribed it as 5 milligrams, but I advised her she could take a half tablet twice a day, so 2.5 milligrams twice a day.
So walk me through that.
Yeah,
She had indicated
This is
to
why
you that
everybody in my family is in the medical field.
she wanted to
My
slow
great grandfather was
the
a
taper.
doctor, number one.
Yes.
And then
then
you said
everybody else
that
could
wasn't
be either
a good
nurse
idea.
practitioners or
And then
CNAs or
on
RNs. And Mom
the
was like,
9th, they call you and say
my mom,
that she
you know,
doesn't want
she
to
was like,
taper.
expect
She
me
wants
to go
stay
into the
where she
medical
is,
field.
right?
I think it was
Got a
that
first
same
cousin
day.
that's
The messages were earlier in the day,
cousin
and then
that's a
later in the
doctor.
afternoon.
I mean, it's all
around.
no. And I
It's
said,
noted at
no, thank you,
16:10, so
because
4:10
I
p.m.
can't
that
keep
she
up
and her
with all them
husband then
dang
called,
medicines.
advocating to
No.
Okay.
stay on.
And in advocating to stay on the Valium, that she reported she's still waking up with panic symptoms and having intrusive thoughts, feeling numb, right?
Yes.
So in addition to agreeing to continue the Valium, did you make a recommendation about the Seroquel?
Continue the titration.
So when you say titration, what does that mean?
So I had recommended 100 on day 1, 200 day 2, 300 day 3, 400 day 4. This is the manufacturer recommended titration schedule to treat manic symptoms. Because again, I had shared with her, I think this is a mixed manic, hypomanic state. So that's what I was targeting.
Okay, and so as far as Seroquel goes, there's some guidance you get about Seroquel that's put out by the FDA, right?
Correct.
And it talks about dosage and administration for every drug, essentially, right?
Yes.
And as far as Seroquel goes, there is different recommended dosages or ranges for different mental illnesses that you're treating.
Correct.
So in this instance where bipolar is in your differential diagnosis and you're recommending titrate up to 400, is that consistent with the thought that you believe she had bipolar diagnosis?
Right. So I was thinking it was a mixed manic state or possible hypomanic state. A mixed manic state is when patient has symptoms of mania, like poor sleep, no loss of energy, but they also can feel depressed, numb, suicidal. It's sort of like it's a mixed state. It's a mixture of symptoms. That a mixed state presentation is clinically acute. It's unstable. So I really wanted to get the manic symptoms under control. I really wanted to get her to sleep.
And so going up slowly to 400 milligrams, is it, what's the recommended dosage range for somebody with bipolar disorder of Seroquel?
For somebody, a manic presentation, you can titrate over days rather than weeks. You can actually go up to 800 milligrams.
Holy.
And so even though you had previously indicated to them in your December 6th meeting that you were agreeable to discontinue Seroquel
milligrams
based on her presentation in the days following, did you change your recommendation?
Correct.
Lordy day, honey.
And
That's crazy to me.
with the increased Seroquel that you had requested as of December 9th, she was reporting sleeping better, right?
Correct.
And that had been something that had been a recurring concern in your interactions with her, sleep.
Yes, my understanding was that she had been sleeping poorly since October.
And was there, when you say you were recommending partial hospitalization during that phone call, did you give a particular place in which you would recommend her to try to seek treatment?
Women and infants.
And that's in Rhode Island?
Rhode Island.
And are you familiar with whether they have particular perinatal or
Have you ever
postpartum
tried
programs
Ambien?
there?
They specialize.
I've been on Ambien for almost 10 years. I take 10 milligrams every night. It works like a charm. One Ambien, you're out.
After that call with the Clancys on December 9th, when was the next time you had contact with Lindsay?
December 9th was a Friday, so I believe it was Monday, December 12th.
Now people are able to send my chart messages all hours of the day, every day of the week, right?
Correct.
But in this instance, you did not receive any messages over the weekend?
No.
So the next my chart exchange was actually on December 12th of 2022, correct?
Correct.
Well, Ambien makes my husband not want to sleep. So it has totally different effects on people.
Now, on December 12th, do you recall who initiated the contact via my chart?
Lindsay?
And at 1:59 p.m., she sent a message to you saying, I've been noticing on my Apple Watch that my heart rate has been fluctuating more than usual. It has been going from 56 to 136 within a matter of minutes. I'm wondering if this is a side effect of the Seroquel and if there's anything I should do about it. Thanks, Lindsay. Do you remember getting that message?
I do.
And again, at that point, as of December 12th, you had recommended the titration plan going up to 400, right?
Yes.
So by that Monday, where should she have been if she was following your instructions?
400 milligrams.
And did she report to you whether she took 400 milligrams of Seroquel?
She reported she was taking 200 milligrams.
Did she say why?
No.
But your recommendation was that she should have been up to 400 at that point.
At that point, yes.
As far as the concerns about the fluctuating heart rate, were you able to address that with her in a response?
Yes. I explained that medications like Seroquel can cause something called orthostatic hypotension, which is basically when you get up from sitting or standing, your blood pressure doesn't compensate in time, so it goes low and people can feel dizzy. I explained that the mechanism for that is alpha adrenergic blockade, so the alpha receptors that help us with like adrenaline. They're also part of the picture here with Seroquel. It's often accompanied by orthostatic tachycardia, meaning getting up from sitting to standing, your heart rate can fluctuate. I said both can be common in the first days of medication exposure or when the dose is being increased. It's generally benign, meaning non-harmful, and self-limiting, meaning it goes away on its own over time. I also advise it sometimes necessitates slowing a dose titration or dividing a dose into like 2 or 3 smaller doses.
Okay. And so with this response and trying to address these concerns, you're aware that she had spoken to the nurse that morning.
Correct.
And that she had expressed to the nurse a desire to get off the medications altogether.
Correct.
And what was your response to that concern that she had in the call to the nurse? What did you tell her?
I said, as long as you are aware of the risks, I don't think you've been on Seroquel long enough for it to have a positive benefit on your mood or anxiety. But if you have noticed benefit, the risk would be worsening of mood and anxiety upon stopping the medication. We also discussed tapering off the Valium, which I'm fine with, if you would like me to send along the taper schedule. Being off medication might help you see where you are at baseline, but I do think you are experiencing significant and severe symptoms of postpartum depression that needs to be treated. I acknowledge that medication alone is not always the best option for someone, but often it's part of the puzzle. Other treatments include counseling, support from others, exercise, healthy diet, yoga, and relaxation techniques. I know this has been brought to your attention several times, but I strongly recommend a partial hospitalization program so that you can get started on utilizing these treatment methods for relief.
And you were aware at this point, as of December 12th, that she had met with Letitia Dukes at least once, right?
At least once, yes.
She had been given referrals for CBT or cognitive behavioral therapy programs out in the community, in her community, right?
Yes.
There have been other recommendations for her to obtain a partial hospitalization program at that point.
Yes.
Now, anything about these exchanges that made you concerned that you had to kind of raise the level, meaning call her in for another meeting or make any sort of recommendations for inpatient hospitalization?
Not at this junction.
And why is that?
She wasn't reporting any acute safety concerns in these messages at this point.
It's just physical,
just physical
side effects.
Physical side effects, yes.
So the messages continued on December 12th, correct?
Correct.
So at 2:44, Lindsay messages you saying, "Thank you, Rebecca. It does seem to be orthostatic, and I'm glad to hear that it's benign and known side effect." And then she tells you a little bit more about the prior nights, right? So she says, "So the last 3 nights I've taken 2.5 milligrams of Valium and 200 of Seroquel. I have to say that I do like the way it makes me sleep very deeply and soundly for around 7 to 8 hours, but I don't like the way I feel in the morning and most of the day. Incredibly depressed and unmotivated to do anything at all. What would you recommend for tonight?" Is that the next message after you explain to her the side effects?
Yes.
Okay. So, and for 10 p.m., you respond to her, don't you?
Yes.
And what did you recommend to address those concerns about incredibly depressed and unmotivated?
So at this juncture, I recommended at least continuing the 200 of Seroquel because at least now she's sleeping. So I felt like although I had recommended getting up to 400, we had gotten
the Tupac
sufficient
just after 30 years
activation symptoms down. She was sleeping.
If found guilty,
and the 2.5 of Valium. I think I advise that we need to give time for Seroquel to work for your mood.
Update on that.
Let's continue to accumulate good nights of sleep, as this can only be a good thing in terms of recovering and feeling better moving forward. I would say take them tonight, and we will discuss further at our visit tomorrow.
And you had a visit scheduled for December 13th, correct?
Correct.
the message continues on that day where at 7:17 p.m. where she says, okay, thank you. I need to make our visit virtual tomorrow. I will not be able to make it to the office.
The
Can
way
you
you
please
support
change it to that?
platforms as well as that you help build
Is that
them,
right?
follow them. and
So
what's true crime.
after having met in person
Today's
with
live
her on
goal
December
is
6th,
10 of these hand hearts.
having
We have 8
had
of
subsequent
them.
communications
Now, I
with
know
her all through the date of December
I know
7th and kind of,
that
again,
in
changing a little bit
524
about the
fold in this
medication
room, there are
plan
2 people.
and having further communication
One
with
heart
her
group.
on
That way we
December
can reach our
9th
goal, help
and now
the
December
algorithm,
12th.
search the channel.
The plan
and
was
we
for
can
her to
continue
again
our
come in
progress.
person
Thank
on
you,
the
Anita.
13th,
Thank
correct?
you so
That was my
very much.
recommendation, yes.
You've
Why
been
did
in
you
the
recommend in
hospital,
person
correct?
at that point?
This was somebody who was communicating with me every day, and I did feel
Yes,
that she had
I
significant
do, honey.
symptoms of depression,
Notice how
some
detailed
mixed symptoms
this
with
nurse
mania,
practitioner
anxiety. I
is.
felt that her symptoms were severe and significant enough that I wanted to touch base with her weekly, and I wanted to see her in person. But again, I was okay with her doing virtual because I'd rather see her and lay eyes on her and try to treat her than not see her at all, if that would have made her just cancel the visit outright.
Thank
Because
you so very much.
generally you do the same thing whether you're in person or virtual, right? As
Right.
far as getting the history, going through symptoms, asking how they're feeling, doing the mental status exam, right?
Mm-hmm.
Thank you for the cow. Moo.
So you meet with her on December 13th at 10:30, correct?
Correct.
And now this is a virtual at her request.
Yes.
And do you revisit with her kind of the events and the changes that you've gone through the MyChart messaging?
Yes, I structured my note as like a recent
Thank
treatment
you.
timeline. So
I
I
want
put,
everybody to throw up
12/6,
a
what had
prayer
happened,
for Miracle
12
for Maddie
9, what had
and Hannah, who's
happened,
Maddie's
and then
mom.
I write update
They
today,
are at
12
the doctor
13.
right
That's
now.
sort of
Her
for
daughter
me
suffers
to
from
like
cancer. So I
remember
always want to keep them in my
the
thoughts and prayers
treatment history that I've
as
had
they
with her
navigate
so
this
far.
difficult journey.
Okay. Because while the MyChart messages are available to you, they might be in a different place, right? So they're not all contained within your same note.
Right. So I made note of, again, our visit on 12/6. I made note that she and her husband had called me on 12/9, and then I made note on the 13th. So I wasn't documenting all the MyChart messages, but just sort of my visit history with her and phone calls.
Okay. And so when you saw her in this virtual visit on December 13th, was she reporting improvement in her sleep?
Yes.
And how was she sleeping during that time period?
7 to 9 hours.
Okay. And that was holding at 200 on the Seroquel?
Correct.
And was she taking anything else daily?
Valium, 2.5, just once daily at night.
Okay. And while she reported sleeping better, she still had significant symptoms of depression, right?
Correct.
And what were the symptoms she articulated?
Hopelessness and, again, anhedonia, that feeling no pleasure, feeling numb.
Okay. And
Holy crap, Shadow.
she also kind of complained of that racing heartbeat, and that's tachycardia, right?
Yep, the orthostatic tachycardia. So I recommended holding a bit longer at 200 milligrams. At this juncture, she had been on 200 milligrams for 4 nights. I wanted to continue it for a full 7 nights. And then we were still discussing whether to taper benzos, and our plan was to kind of slowly phase them out at that point. So we were going to decrease from 2.5 milligrams daily to 2 milligrams for 7 days, and then we were going to reassess at our next visit in a week. I also provided psychoeducation about behavioral activation, CBT techniques to utilize for depression. I also recommended postpartum.net for support groups, and I reiterated that she consider a partial hospitalization.
And again, during this telehealth visit, you have this conversation with her, but you also do your mental status exam. You make observations of her, right?
Yes.
Did you observe any
I went to one day of that.
signs of mania?
No.
No.
Did you observe any signs of psychosis?
No.
Did she articulate to you any suicidal ideation?
She had endorsed that she had had thoughts of it on the Edinburgh over the previous weeks, that she sometimes had thoughts of harming herself, but not at that visit.
Full.
Okay. And would that have been something you'd follow up on? Would that statement from the Edinburgh? Or
Objection. Would that be something you'd follow up on?
So I'll allow that.
So just to clarify, so again, the Edinburgh,
After coming from the witness judge, I'm sorry.
Objection overruled. Next question.
the Edinburgh is over the previous 7 days. So she had that thought sometimes when I asked her, are you currently having SI? It was no during the visit.
okay. And it just was the response sometimes.
Yes.
And so did you ask further in your interaction with her on that day on the 13th about whether she was experiencing suicidal ideation?
Yes.
Did she say she was?
No.
Did she indicate whether she had any plan or intent?
No.
And as far as intrusive thoughts, did she speak about intrusive thoughts during that meeting?
No.
Did she tell you she was having horrible thoughts?
No.
She had previously used that terminology in your MyChart exchanges, correct? At some point?
I do remember the intrusive thoughts that she would mention. Intrusive thoughts. I don't recall horrible thoughts
Okay.
in my chart messages.
As far as the intrusive thoughts,
Mhm.
were they things that you followed up on in your telehealth or in-person visits?
Mhm.
And was she able to articulate to you?
Yes. Yes or no? Sorry.
Was she able to articulate to you what types of thoughts she was having?
Yes.
What were they?
Intrusive suicidal thoughts.
So thoughts of harming herself or just wanting to die?
Thoughts of wanting to die.
So you put them in the.
At any point, did she ever indicate to you thoughts of wanting to harm her children?
No.
You don't say. Well, that's where I knew medicine.
So at the conclusion of this visit on December 13th, what was the plan?
I'm about to throw down right
The
now.
plan was to continue Seroquel 200 milligrams and Valium 2 milligrams.
Okay. And again, in this December 13th meeting, did you also indicate to her that she should engage with other services like support groups or partial hospitalization programs or CBT?
I did.
Do you recall whether you received any MyChart messages from her after that visit on the 13th?
I did.
So
I actually sent her a message on the 13th.
okay. So on the 13th, you meet with her at 10:30. At 2:27, you sent her a message. Why?
I wanted to send along some more ideas and information on what she could do to help herself feel better.
Because even though she was reporting sleeping better, she was still presenting with these depressed symptoms, correct?
Correct.
And so in the message you sent her on December 13th, it's actually a fairly lengthy message that talks a lot about cognitive behavioral therapy, right?
Yes.
And the benefits of it, and sends encouraging words.
Yes.
Does she respond to you on the 13th?
No.
The next contact you have with her, is that in a MyChart message on December 16th?
Yes.
And December 16th, 12:50 p.m.
Oh, no, I apologize. The next contact with her, there was a telephone call on December 15th.
Was it with you or was it with a nurse?
It was with
live
me
right now.
and her husband and Lindsay.
Sorry about that. So December 15th at 3:53 p.m., you have a phone call with them. And what do they report to you in this phone call? What does Lindsay report?
They informed this has been the worst day for Lindsay is having persistent intrusive thoughts of suicide, no active plan.
Where?
But both Lindsay and Patrick agree that higher level of care may be necessary at this time. Discussed options, they state they are likely to go to MGH ED as they have perinatal psychiatry as well as an inpatient psychiatric unit. Lindsay also deciding about McLean. This writer advised that they keep us posted and sign a ROI, release of information, so that we can communicate with treatment providers
You're
at higher
welcome
level
to
of
get
care.
together on
Lindsay
YouTube
verbalized understanding and agreement.
username. Well, it's
So,
at Steph's case.
On
I'll
this
say
phone
logo on
call that
YouTube.
you had with them on 12/15, what prompted the recommendation that they go to the emergency department?
Again, they had described it as the worst day and was having persistent intrusive thoughts of suicide. And they were at the point where they were ready to get assessed for a higher level of care.
And was this different than some of the other communications that you've had with, or that you had with Lindsay Clancey over the course of the weeks?
I would say so.
And so you talked to them about the process of going to the emergency department and the potential for going to McLean for inpatient?
Now, she
I
does
recall
go
advising
McLean,
them that
on New Year's Eve, December 31st.
if they were to go to their nearest
she was
ER,
discharged 5 days
which would
later.
either be
Does go,
BI Plymouth
just not
or
on the
South
state.
Shore Health, the process would
That
be
should have
that
happened
they would
immediately.
get evaluated. But if they were determined to need to go to a higher level of care or an inpatient psych, those facilities did not have inpatient psych units. So they may be sitting there waiting for a bed at any first opening in the state, which could be, up in Amesbury or Newburyport. But that if they were to go somewhere like MGH has a unit called Blake 11, which is a psychiatry unit, and oftentimes they prioritize admissions from their own emergency department. MGH and McLean are also combined under the umbrella of what's now MGB. So sometimes if somebody presents to MGH ED and there's no beds at Blake 11, they might reach out to McLean and try to get them in to McLean.
So you communicated all of this information to them to kind of give them options on what the best course might be to get inpatient.
Yes, I summarized it in my note, but that's my recollection of the phone call.
Okay. And you're aware that that Ms. Clancey had been employed at Mass General as a labor and delivery nurse?
I was.
So they were familiar with that facility.
So I did ask, would you be comfortable with that?
Uh-oh, we're frozen.
And so then you were able to communicate with Lindsay via my chart that next day on December 16th, correct?
She reached out to me on December 16th via my chart, yes.
And she indicated to you on December 16th at 12:50 that she, after visiting the ER yesterday, I opted to remain outpatient and pursue the partial program at Women and Infants. And Women and Infants, that had been the program that you had previously recommended in Rhode Island, correct?
Correct.
She indicates, I'm waiting on a call back for them to schedule. In the meantime, I want to know how to proceed with my meds.
More.
Do you still recommend the 2 milligrams of Valium and 200 of Seroquel nightly? Again, it's making me sleep well, but still not improving my mood. So I will need a refill on those meds. Please let me know. So in this particular message, she indicates to you that she was waiting to schedule with Women and Infants, correct?
Correct.
Were you aware that prior to that Letitia Dukes had already initiated the referral process for Women and Infants?
Yes.
And so on this particular message, she's kind of updating you, but also asking you if she should stay on the same track for her medication.
Yes.
And what was your response? So December 16th at 1:14.
I said, hi, Lindsay. I know Letitia may have called you yesterday about information about Women and Infants, so I hope you were able to connect with her. Target dose for Seroquel treating depression is 300 milligrams, so we can increase it to 300 milligrams if you are willing. Yes, continue the Valium. Let me know what you think.
And why at this point did you recommend increasing now to the 300 after having recommended staying at 200 for the Seroquel?
The FDA recommended dose for treating depression, bipolar depression, Seroquel is 300 milligrams.
I have to say,
So
best
on
one
December
so
16th, you continue to have
as
messages
far as
with
detail and know what she's talking
my chart
about,
messages
being on
with
point
Lindsay
and being
Clancey,
able
correct?
to answer
Correct.
directly.
In any of,
That's practitioners
or
on
do
her
you know that she
team.
went to see her previous psychiatrist on that day, December 16th?
Yes.
Yeah.
And so in her messages later in the day at approximately 2:11 p.m., she indicates, I spoke with my original psychiatrist after my ER visit, and she recommended adding 25 milligrams of Lamictal to stabilize my mood. Is that something you would agree with? Had you ever talked with her about Lamictal before?
No.
Is it a drug that you kind of commonly recommend for people?
I do.
And was it something that you thought could be a good fit for this patient?
Yes.
And so in your response to her at 2:26 p.m., do you further talk about using it as a mood stabilizer?
Yes. I state absolutely lamotrigine works well for mood stabilization and depression. I talked to her about the side effects of it.
And fair to say those side effects are like rash and skin changes, fever.
Can we find out what the witness feels the side effects are rather than counsel?
Well, why don't we let the question be
Thank
what
you,
was she
Dana.
told?
Thank you.
All right. That's the proper question. So why don't you ask what was told or what was said or messaged to the defendant?
Can you tell us what you messaged her the side effects were?
So I recommended it needs to be a slow titration, meaning titration, increasing the dose due to risk of SJS, which means Stevens-Johnson syndrome, which can be a very serious rash that somebody can get. There's a higher risk of it if somebody
Thank
takes
you, Katie.
Lamictal,
I
which is why the
appreciate
FDA recommends such a slow titration, 25 milligrams for 2 weeks, 50 milligrams for 2 weeks, 100 milligrams. You can't really go quick with it. But I also specified it can cause a benign rash as a side effect. So any skin changes you notice, you want to be sure are not accompanied by things like fever, malaise, pharyngitis, swollen lymph nodes. Also watch for a rash that is purpuric or tender. Benign rash would be spotty, non-confluent, non-tender, and no systemic features like fever. Otherwise, I find this medication to be quite well tolerated. Take with food to minimize any risk of GI, such as nausea. I will send this to your I can send this to your pharmacy along with the dose change in Seroquel. Any luck with hearing back from women and infants?
So the Lamictal, am I saying that correctly?
Lamictal.
Is that something that you would add to the Seroquel?
Yes.
And why would you add it to Seroquel?
They work differently. They have mechanisms of action, and they can work well together.
And so at that point, on December 16th, do you recall kind of what the last version of the medication recommendations were?
From me?
Yeah, so
I
at this point, you added a medication. So what was on the prescribed or recommended list for you, for her, as of December 16th?
So I asked her if she needed me to send along the lamotrigine, and she said that she had had her psychiatrist send it along.
Okay, so, but as far as now what you know to be the medications that she's been advised to take, what are they at this point, December 16th?
Lamotrigine, 25 milligrams, Seroquel, 300 milligrams, and Valium, 2 milligrams.
And the Valium, is that still a daily recommendation?
Yes.
Let me ask, why do you think they had Dr. Tufts yesterday and then her today? Seems like, would you put these in chronological order?
At the end of that message that you just read, you asked her if there was any luck
And
with
when
hearing back
did
from women and infants,
the doctor
correct?
that testified
Correct.
yesterday?
Did she respond to you in a message about what was happening with the women and infants? The next message at 2:33?
In 2:33, She said, unfortunately, missed the call this morning from women and infants, but I did request them to call back. I'm hoping they do so today.
And
Yeah.
you said
Yeah,
that
she was.
you'd also learned in this exchange that her other psychiatrist had already called in the lamotrigine prescription.
Correct.
And then, did you have any further communication with her on 12/16?
I said, okay, sounds good. I hope so as well. And that was it.
As far as the DNA on the band,
When's the
DNA
next time
being
you
on the
spoke with
extra
her?
bands and not Lindsay's.
12/16 was a
what I
Friday,
feel
so
has
I spoke to her
happened
on
is
Monday,
when he saw the
December
children
19th.
in the basement, he did
And
run
again,
over
did you
to those
speak
bands
with
off
her via the MyChart
children.
messaging,
Okay,
or did you
so
speak
I
to
feel
her
like
on the
he's
phone?
just
My chart
all
messaging.
over, and he's trying to save his children. So I feel like his DNA wiped
And
off
were
her.
you
I
aware
really
that on
do feel like
December 19th she had another appointment scheduled with Letitia Dukes for that morning?
Yes.
And
probably after lunch, Sarah.
in your communications with her via MyChart, they started at 11:04 a.m. on December 19th.
Yes.
And does she indicate to you in that message that she is starting with women and infants partial hospitalization tomorrow, meaning the 20th?
Yes.
And that she's concerned because she has an appointment scheduled with you already, and she's asking what she should do about that, correct?
Correct.
That
And
drama.
what was your response to her?
So she has an appointment, but should be in the program. Should I call and cancel or reschedule because she thought the program would be starting her medication? I said, I'm so glad you were able to get into the program this week. That's great. So feel free to call and reschedule. The only issue is that I am on vacation next week, so it might be 2 weeks out that we touch base again. If that's okay with you, let me know what you think.
Okay. And her response at 1:24 that says, I think since I'll be followed by women and infants, that 2 weeks out will be okay. My only concern is potentially needing more Valium before that. I'm trying my best not to take it at night, but have still been taking 2 milligrams every other night. Can we refill that just in case I continue to need it, right?
Right.
So at that point, when she sends that message saying she needs the new prescription for Valium, was that in line with the recommendations you made for a taper of Valium?
I had recommended that she take it daily.
And so in this, she indicates to you that she's trying not to take it at night, but taking it every other night.
Luke's wife, I love you.
And on December 19th, you respond, sure, no problem. When will you be out of Valium? And she responds, I'll run out tonight.
Yep.
And then you agree to send in a refill.
Yes, I wanted to make sure she had an appointment rescheduled with me, and then I would refill enough of the Valium to get to that next appointment.
And so did you refill the prescription based on what she reported she was taking, or what your recommendation was that she take of the Valium?
What my recommendation was that she take.
Yours, right? Not Patrick.
And so do you recall receiving a message on December 20th via MyChart from Lindsay?
I do.
And she reported to you that she had been discharged from women and infants that day, correct?
Correct.
I know he didn't do it.
And that they recommended she find help getting
know he didn't
off
do
the
it.
Seroquel, and that she was
I've been preaching all
indicating
morning
that she'd
today.
like to taper the
But there was a
Seroquel.
section earlier where he was talking
Yes.
about she wasn't
Did
bipolar.
you respond
and I
that
was
day
just
or the next
joking
day?
that. Anyway, if you wasn't
The
here
next day.
earlier, you didn't. That makes sense.
Her message came in at 8:05 p.m., so I responded the next morning.
Okay, 10:57.
Yes.
And what were your thoughts about her report that she was discharged and the recommendation for tapering the Seroquel, or getting off the Seroquel, I should say?
I said I'm not opposed to that. However, I'm concerned she discharged you, as I do feel you could benefit from the groups and added support separate even from medication changes. In fact, if we're not going the medication route, I think groups and therapy are the treatment needed, as I feel the intrusive thoughts you've been having are nonetheless concerning, and I know they've caused you considerable distress.
Don't do group
I'm
therapy.
also on vacation next week, so I'm hesitant to start a taper when I am not available to you for questions and concerns. Again, I'm open to starting a taper, but I want to be available to you as it happens. You mentioned you are connected to your previous psychiatrist. Would that be someone to consult as well?
And so when you sent this message at 10:57, were you
Muted.
opposed to the idea of tapering the Seroquel?
I understood that it was helping her to sleep. And I also understood that she felt as though she was still depressed. And she wanted to come off of it.
And in this correspondence, back and forth
right.
on the
My coverage here,
21st,
they probably got a few more.
was there
before
any
they got a lunch.
conversation
My dog
about
is
the
45 minutes
lamotrigine,
past,
and whether she took it as a mood
and he
stabilizer?
is mad.
No.
So I'm going to end my coverage for today. You can keep
As
watching
far
this
as
on
coming off
Associated
medication,
Press is live on YouTube, Court
was
TV,
that something that
any
you
of those
thought
platforms.
might be a
okay?
good option
If
for
you
her?
have not followed me yet, please make sure you do that right now
As
before
I
I
had
exit.
expressed to
That way you
her,
can find your way back because
I
I'm going to be live again tomorrow in the
hesitant.
morning, 10:30 a.m. Eastern
it could be
Standard
done,
Time.
but she would
Probably
need
10
a lot
because I
of
came on early
what
this
I would
morning.
recommend to be
So
group
at the
support,
start
therapy,
of tomorrow's trial, I'll
other
try to
types
cover
of
it at least
treatment.
to lunchtime.
At that point,
Seems like they're a
based
little
on
bit late on
your,
lunch today, so
interactions
I
with
tried to
her
wait
through
it
the
out.
clinic, through
But
all
the
the
dog is not
messages,
going to
through
wait
the
on
meetings that
me,
you've had,
so I got to go.
were you
I
aware
love
of
you
whether
guys
she
very
was
much. I
getting
want to
any
thank
other
you for
support,
spending
like
your time with
groups,
me today. I
other than
really
Letitia
appreciate you
Dukes
being
and yourself?
honest with me and
No.
sharing your opinions and showing up for our
And
show.
this
It means
partial,
the world to me. I want you to make sure you're following me on every social media platform. All you have to do is look for the same username and
are you aware of whether
logo.
she was?
I'm everywhere, especially
I was aware it was
Facebook,
recommended. I was
Instagram,
not aware
that
that
I
she
never use, but I'm
was
still on there.
interacting with any
YouTube
groups.
and all of
And
those
the
other
self-share perinatal
social
behavioral
media
program,
platforms,
you
and
have
of
groups
course
that
here.
are offered through the clinic, correct?
At
You
that
have
time,
spent
we
time
did,
with me
yes.
today that
And
you were
if
never
she
able
was
to go back
attending
in your
groups
life, and
through
for
the
that I am
clinic, would
forever
that be
grateful. But the
something that you
most
would have
important thing
access
for
to
me
or be
today
noted in her records?
is that you are
Yes.
kind to one
And as far
another.
as your
That's what you
communications
do.
with her, did she report to
Thank
you
you
that she
for
was
everything.
attending
And
any
I'll
sort
see
of
you
groups or
tomorrow.
therapy at other
Thank
places
you,
in the
YouTube.
community?
No.
The only